Just keep it muted. Okay, good afternoon. Today we will have three topics. The first one will be ventilator management for the first 2 hours. then hour and a half with Dr. Whitey for the endocrine emergencies. Then we will have hour and a half for ACLS. Everybody prepared for the ACLS? And the ACLS will split into small groups, and every group will run one of the cases with Dr. Bailey, who is doing the ACLS a lot, and she's ED doctor. Great. So today we'll talk about ventilator management. I have no disclosures. The three topics that we will talk about: the initial vent settings. So we talked yesterday that initial vent settings depends on the ideal body weight and the disease. So we'll talk about different common diseases that we will deal with, and we will see what initial vent settings that we should start with, and we'll go through that through some cases. So you will have option to select the correct answer. Then we will participate in that. Then how to manage overnight problems, and we'll concentrate on 4 problems that we will talk about, mainly hypoxemia, hypercarbia, hypotension from vent setting itself causing hypotension, and high pressures on the ventilator. These are the 4 problems that we'll talk about. Then we'll talk in the last portion about how to titrate the vent settings down, and this is what we call weaning. Then try to take the patient off the ventilator. This is what we call like ventilator liberation also. So there are 3 definitions or 3 things I want you to be aware about what we mean by triggering, target, and cycling. By triggering, are we talking about the patient is stimulating or starting every breath or some of the breath or not? And we call that the patient is assisting. If the patient is deeply sedated or paralyzed, he may not start any breath, and he will follow the vent settings, so he will be controlled. So this is the difference between controlled, means the patient is not starting any breath, and the ventilator, if you set the ventilator rate at 16, he will breathe 16. But if he's assisting, he can breathe above the rate that you have. And target, what are you targeting? Ventilators in general split into 2 large groups: volume targeted or volume limited, and pressure targeted or pressure limited. So these are the 2 major groups. Then other different ventilator types that are mixing the 2 together or using some different changes from that. Cycling, by cycling, we mean what ends the inspiration. What ends the inspiration. In volume targeted, after you get the tidal volume you are setting, inspiration will end and expiration will start. But in pressure targeted, you don't have a specific thing to end the inspiration, so you have to set an inspiratory time. You have to set an inspiratory time, how many seconds or part of the second after that the inspiration will end. In patient with pressure support mode, you have flow, so the expiratory flow, when it decreases to a certain percentage, the inspiration will end. And usually when you reach 25% of your maximum expiratory flow, the inspiration will end and expiration will start. So what we mean by cycling, what ends the inspiration, this can be the volume and volume targeted, set inspiratory time in the pressure targeted, and decrease of the expiratory flow to a certain percent of the maximum flow will end the inspiration and will start the expiration. Any question up to now? You got it? Also, we are building on each slide. We'll build the next slide. So controlled mechanical ventilation or CMV can be pressure, can be assisted or controlled. So if you have AC, this is assist control. If you have CMV, controlled mechanical ventilation, controlled means, as we talked, the patient is deeply sedated or paralyzed, does not do any extra breath more than the set setting. While assisting, he can do extra breath. Same thing for the pressure control. If you are on pressure targeted or pressure limited, can be controlled or assist. This is the pressure support. For pressure support, you need your patient to be awake to start the breath. That's why if you see in this first one here, curve to the left, you see the pressure goes down first, then goes up later on. So this going down is what the patient start the breath. So he starts the breath, so you will create negative pressure. So in the pressure time curve, you will see this negative thing down. I can point to it here. So this negative part here is the patient starting the breath. So if your patient on pressure support, that's why sometimes they tell you pressure support trial failed because the patient is apneic. He's not starting the breath. and your ventilator will have alarms, and some ventilators like the ones we have, if you have a specific low rate, it will turn him off automatically to the full vent support. Make sense? So this is the pressure support mode. You have to have your patient awake to start the breath. Don't put him on pressure support if he's paralyzed. What will happen? Your ventilator is not smart enough, he will die, right? If your ventilator is smart enough, like most of the ventilators now, it will switch into full mode of ventilation to breathe for him. Again, volume limited on the left determines volume, so you guarantee your patient has specific volume every breath, and in this way you guarantee your patient will have at least minimum minute ventilation, which is minute ventilation equals. Yeah, so some people coming from outside answering the question. So it is tidal volume in liter times your respiratory rate. So if you set your ventilator set at 500 tidal volume, this will be half a liter, and you set him at a rate of 16. If he's controlled, he will breathe 8 liters per minute. 1.5 times 16 would be 8 liters per minute. If he's assisting, he will breathe more than the 8 liters per minute. So you guarantee minimum minute ventilation, and this will give you good carbon dioxide wash. Okay, and also some patients like ARDS, you want how much tidal volume? 6 ml per kg ideal body weight. So some people still remember their names today. So 6 ml per kg. So you will guarantee your patient will get the 6 ml per kg ideal body weight. Will not get higher or lower. Make sense? So you guarantee the tidal volume, guarantee the minute ventilation, and you guarantee mostly fixed tidal volume or nearly fixed tidal volume that you want. Okay. On the other hand, the pressure limited, you guarantee the pressure will not go high. We said we don't like the plateau pressure to be above 30 centimeter water, correct. So if your patient on volume controlled or volume assist or volume targeted, and the lung is non-compliant, we'll talk about the compliance in a second, lung is very stiff, non-compliant lung, you may get very high pressures on the ventilator because the lung is very stiff or non-compliant. So in the volume targeted, you don't guarantee the pressure, but you guarantee the volume. And pressure targeted, you guarantee the pressure. So you say, okay, I want inspiratory pressure of 20. So your peak pressure will be that inspiratory pressure that you set plus your peak. So if you are on peak of 10 and inspiratory pressure of 20, your peak pressure will be 30. And usually peak pressure is above the plateau pressure. Now we'll talk about that in details. Make sense? So you guarantee that your pressure will not exceed the number that you want. But in the meantime, if your lung is very non-compliant, very stiff lung, what will happen? Your patient will get very small tidal volume. So you don't guarantee the volume. If the lung is very compliant, you will get very large tidal volume. So you cannot guarantee the volume. It depends on how compliant your respiratory system. And we'll talk, it's not just the lung. There are 4 things that participate in the compliance of the respiratory system. We'll talk about them in a second. So pressure limited, you are sure that you don't get high pressure, avoid barotrauma, but you can get very small tidal volume and you get high carbon dioxide with them. While in the volume targeted, you guarantee your tidal volume, your minute ventilation minimum, but in the meantime, if your lung is non-compliant, you get very high peak and plateau pressures. Make sense? Any questions? Looks like no. Great. So what's the difference between the two? As we said, these are the good things. There's some extra things for the pressure control. They say there may be some more homogeneous distribution of the gas through the lung, and also more synchrony with the patient, so less need of sedation also. This is a slide from UpToDate, the benefits or advantages and disadvantages of the pressure and the volume cycle, volume control. So these are the things that we talked about. Okay, what will you order? If you order volume limited, which is the more commonly used, and one of the good things about it that many physicians are familiar with it more than the pressure control mode. So you will order the tidal volume, and we said it depends on your minute disease and the ideal body weight, and we'll talk about that in more details. You will order your PEEP, FiO2, and respiratory rate. Most of our ventilators, because we use a specific mode in between, we have auto flow, so you don't have to worry about the flow in our ventilators. Okay, so if you will order pressure limited, we have to order the inspiratory pressure instead of the tidal volume. Same thing for PEEP, FI2 rate, and you have to order the inspiratory time. So the I time and the E time, because we said the cycling in the pressure targeted ventilator depends on your inspiratory time. So when you order, you will order an inspiratory pressure and inspiratory time. Make sense? Great. Lung is like a balloon, and this balloon is full of small balloons, which are the alveoli. So we'll get to that concept. We'll talk about compliance. There was a question in the pre-test yesterday, and I think this was a hard question. Many did not know what to answer. So this is what we will learn about the compliance. What's the compliance? Simply how stiff your lung. So the more compliant the lung, the more elastic your lung, the more distendable your lung with the volume that you have. So think about a balloon. Everybody, when you were young, you inflated the balloon. Now they have some pumps and things like that to inflate balloons. But anybody inflated balloon by his mouth before? So many people like me. Okay. So if you have a new balloon, it will be very stiff to inflate, right? So this is a non-compliant balloon. When you inflate this balloon and deflate it 15 times, if it doesn't rupture, so balloon will be more compliant. So it will be easy to inflate. So you need less pressure to inflate this lung. And we talked yesterday about what is the driving pressure, plateau pressure minus PEEP. And this plateau pressure, we call the plateau pressure minus the PEEP, we call it the driving pressure, because this is the pressure change that will happen from the tidal volume that you give to the patient. So if you give, for example, your patient 500 tidal volume and put him on PEEP of 5, and you measure the plateau pressure, and I'll show you how to measure the plateau pressure in a second, you find your plateau pressure is 15. So your compliance will be your tidal volume in milliliter, the 500, over your plateau pressure minus the PEEP. So 500 over 15 minus 5 will be 500 over 10, 50, right? Normal compliance is close to 100. This is one of the things that you can follow every day on your ventilator to see if your patient is getting better or not. If your compliance yesterday was 50 and today is 60, your patient is getting better, regardless of the vent changes that you did. If it was 50 yesterday, today is 40, your patient is getting worse. So we need to think what's going on. Are we developing more ARDS? Are we developing effusion? Are we developing pneumothorax? Are we developing something like extra volume in the lungs? So do we need to diurese? So we need to see what caused your compliance to go down. And this is what we call the static compliance. There is dynamic compliance, will not bother you much with that, but this is for higher level, we teach that for first. So compliance is your tidal volume in ml over your plateau pressure minus your PEEP. Number getting higher, patient getting better. Number going down, patient is getting sicker. Make sense? Any question? What can cause the compliance problem? I'll get to that in a second. Let me show you how to measure the PEEP, the plateau pressure in our ventilator. When you look at your ventilator, it will give you the peak pressure and will give you the mean airway pressure. And we'll need the mean airway pressure in a second when we talk about what we call oxygenation index. So without doing anything, but to look for the plateau pressure, you need to click this button in inspiratory hold. What you'll see this arrow. You click this arrow, in few seconds, it will measure the plateau pressure for you. And here the patient had peak pressure 25 and plateau is 19. If your patient has plateau pressure, peak pressure less than 30, you don't have to measure the plateau pressure, because definitely plateau pressure will be less than 30, unless you want to calculate your compliance. Okay, so if you are in rush, you have a lot of patients, you look at the ventilator peak pressure is 25 like this patient, definitely your plateau pressure is less than the 25. So you may not need to measure it, but if you want to measure it to calculate the compliance, this is another. Beside that, there is some button here called auto PEEP. When you click on that, will open an arrow and you push the arrow and will measure the auto PEEP for you, or the total PEEP and the auto PEEP. So if you are on PEEP of 5 and you measure the intrinsic PEEP and it is 15, 20, then you are auto PEEP. Make sense? Can be a little bit higher, 5 PEEP, and you measure it at 8, that's okay. So, but if it is way higher, then your patient is auto PEEP, and we'll talk about that in certain patients. Okay, so these are the 4 things that will reduce your compliance, not just the lung. Lung pleura, chest wall, and even the abdomen. Like Dr. Baweja yesterday was talking about orthopnea and 90% specificity for heart failure, but there is 10% can be from abdominal distension. If your patient has ascites, if your patient has ileus. So that's why it's important when you start your patient on ventilator, you need to start them on stool softener so they don't get constipation, distension, ileus, and this distension will push on the diaphragm, will reduce your compliance because lung is not able to expand even with the ventilator with this very distended abdomen. So compliance will not just, so this is what we call respiratory compliance, lung, pleura, effusion or pneumothorax, and chest wall. Somebody who is very obese, his compliance will be less. Somebody who has chest wall rigidity, and we'll talk about that at the end of the lecture, he would have significantly high pressures on the ventilator. Somebody with ascites, distension. What can cause decrease in the compliance in the lung itself? So anything inside the alveoli, water in pulmonary edema, blood in alveolar hemorrhage, plus and pneumonia. Anything inside the alveoli will reduce your compliance. Or anything around the alveoli in the interstitium, like interstitial fibrosis in patients with IPF or ILD, interstitial inflammation and inflammatory lung disease. So all these things, water, interstitial edema and pulmonary edema, all these things will reduce your lung compliance. Okay, so in initial vent settings, we'll talk about some different diseases and we'll see how can we set the initial vent settings. I will start reading the case and then we will have the options. 42-year-old man with alcohol-induced pancreatitis develops shortness of breath on the floor, transferred to the ICU. No cardiac history. On examination, he weighs 100 kilos. He's 5'10". Oxygen saturation 85% on 100% non-rebreather. Chest diffuse bilateral crackles anterior and posterior. No gallop on the heart. ABG, we now are familiar with the ABG. I will not say which is which. So 722, 60, 50, 25 on 100% non-rebreather. Chest X-ray bilateral infiltrate, intubated by anesthesia and RT is asking you for the vent settings. You have these options, A, B, C, and D. Give you a few seconds and tell me which option you will pick. First, what do you think? So we said we need to know two things. What disease you think this patient may have?
ARDS.
ARDS. I'm waiting.
Okay.
Not for the answer, for the question that I asked. No. So what do you think this patient may have? You said ARDS. If you think about one problem, you will miss something else. What else other than ARDS can this patient have?
Can have fluid overload.
Fluid overload, pancreatitis you treat with tons of fluid, can have fluid overload. What else? So he can have ascites from the pancreatitis, but this will affect not much the hypoxemia that he has, but he definitely can have ascites. What else?
Pneumonia.
Can be pneumonia. How many days he's in the hospital? We didn't say. So he's in the hospital, can develop hospital-acquired pneumonia also. What else? Heart problems. He may have underlying heart disease, and we didn't mention he develops acute pulmonary edema. What else? In this condition, he will not be ARDS, right? So because an ARDS, you shouldn't have cardiac etiology causing the hypoxemia, right? So what else? Pancreatitis can develop significant effusion. Can be left more commonly, can be bilateral, can be even right effusion. Okay, so many things. But if we think ARDS, all of you said ARDS. What are the 5 things to say patient has ARDS? We talked about them yesterday. Acute within 7 days. Bilateral pulmonary infiltrate with chest X-ray showing that. Not cardiac. He doesn't have gallop. He doesn't have any heart history. PF ratio less than 300, and the one that this patient does not have should be on PEEP-5. So this patient does not have PEEP-5. Okay, what's the PF ratio for this patient? What's your oxygen? 50. What's your FiO2? 100. So 50 over 1, not 100. Okay, so 100% is 1. So when you calculate the PF ratio, 50 over 1 will be 50. If you say 50 over 100.5, if you see a patient with PF ratio of 0.5, you have to write it in New England Journal because this will be American. Okay, this is a grave PF ratio, the 0.5. So 100% is 1. So 50. So this patient has significant ARDS, lower PF ratio than the 300, way lower. You think if you put him on PEEP-5, his PF ratio will cross the 300? Most likely not. Okay, great. So somebody wanted to say the answer. So what's the height of this patient? 5'10". What's his ideal body weight? 73. You remember from the question yesterday, 73 kilos, right? 73 times 6 will be, yeah, 4. So the closest will be 450. D. So D is the correct answer. 450 fast rate to compensate for the small tidal volume for patients with ARDS. We need to start 100%. He's starting 85% on 100%. So you need to start with 100%. Then you need to start with PEEP higher than 5. No, in any patient that you intubate for hypoxemic respiratory failure, start PEEP of 8 or higher. And I'll tell you in a few slides why. So don't start patient with hypoxemic respiratory failure on PEEP of 5. Because what you need to do, you need to lower the 100%, because 100% is injurious, right? So 100% oxygen can cause lung injury, can worsen your ARDS. So you need to lower that. To lower that, you need to increase the PEEP. And if you increase the PEEP, you qualify for what we call VAE, and we will talk about that. And this is something very important to avoid, if not necessary. And when we reviewed our patients for VAE, we found 80% of them were intubated on PEEP of 5, and they were increased from 5 to 8. That's why our policy to start any patient with hypoxemic respiratory failure on PEEP of 8 or higher. Make sense? So this is very important, and this will reduce. So everybody agrees with D as the correct answer. 6 ml per kg ideal body weight, which we calculated 73 kilos. So 450 tidal volume, fast rate to compensate for the small tidal volume, so you don't get very high carbon dioxide and low pH, then 100% and 8 of P. Okay, we know from 2000, New England Journal, multi-center study predominantly was started, or the main center was in Canada. They call it the ARSNet study, and they looked at comparison between 6 ml per kg ideal body weight and 12 ml per kg ideal body weight. Okay, so this study showed reduction of mortality from 40% to 31%. So absolute reduction in mortality is 9, but also showed more days of ventilation. But in this study, they kept the plateau pressure less than 30 centimeter water. So if your plateau pressure was more than 30 centimeter water, they reduced the 6 ml per kg to 5 ml per kg. Still above 30, they reduced from 5 to 4. If it was still 30, they can switch to pressure control mode. So it's not just the 6 ml per kg, you have to keep your plateau pressure less than 30 centimeter water. Okay, let me go back, because they love that in the board, the number you need to treat. So we said this reduced the mortality from 40% to 31%. So what is the number you need to treat to save one life? 11. So right. So 9% absolute reduction. So 1 on the, then this will give you 11. Okay. Makes sense. So this is how you calculate the number you need to treat. Similar questions can be a number you need to screen or something like that to pick something like that. The number you need to treat. This is one of the statistics question that they love a lot in the boards. This is from UpToDate also. So this is how to calculate the ideal body weight. So 50 kilos for the 5 feet for men, 2.3 kilos for every inch above, 45 kilos for women, and for the 5 feet, and for every inch above the 5 feet, you add 2.3. How about if your patient is 4'11", man 4'11", what will be his ideal body weight?
Okay. Ideal body weight.
50. So you go down. So 50 minus the 1 inch, 2.3. Make sense? Great. You had the patient admitted, and you put him on ventilator, and you wanted the vent settings, and you told the nurse, please get me his height and to calculate your ideal body weight. First time to the hospital, no family around, patient is already intubated. Nurse went and she came back to you, oh, patient has bilateral BKA. How do you calculate his height? Yeah, arm span, right? So arm span is nearly the height. Okay, so another patient, first time to the hospital, you wanted to calculate his ideal body weight, told the nurse, go and check his height. She came back, he has bilateral DKA. You told her, okay, go and measure the arm span. She came back and told you he has bilateral arm amputation. So how do you calculate his ideal body weight? Yeah, so head to symphysis pubis times 2. And actually, we had 3 patients like that. One of them is already in the hospital here. I don't know if anybody is taking care of you. He has Fanconi syndrome and has a lot of fractures of his arms and legs. And this is how you see my note. His expected height is that much, and we calculate his height, his ideal body weight, and his tidal volume about 300 or 350 or so. Based on that, we had another patient with dwarfism, normal torso, but his arms and legs are short. So this is another situation. Then we had another patient with osteogenesis imperfecta, had significantly fractured arms and legs and deformed, and this is how we calculated the ideal body weight. So here they tell you also, if your patient has plateau more than 30, decrease it to 5, then decrease it to 4. If your patient has plateau less than 30, and your carbon dioxide is high and pH is low, they allowed in the study to go up on the tidal volume up to 8 ml per kg. That's why you hear a lot, even you see that in UpToDate, that tidal volume for ARDS is 4 to 8 ml per kg, but the study was targeting the 6 ml per kg ideal body weight. Only they went higher than 6 if your plateau pressure was lower, and only they went lower than the 6 if the plateau pressure was higher than the 30 centimeter. Okay, so this is the modified Berlin, and this is the reference on the bottom if you would like to read the study. So acute within 7 days. Some people think maybe acute you can use 6 to 72 hours, but it's okay to use up to 7 days. A bilateral infiltrate on the chest X-ray, PF ratio less than 300. We used to use 200, and we used to call 200 to 300 as acute lung injury before 2012. Now they said there is no acute lung injury, all is ARDS, but different severities. And they divided the severity in this study between mild and moderate and severe based on the PF ratio. So 200 to 300 is mild, 100 to 200 is moderate, and less than 100 is severe. And this classification correlated with 2 things: mortality, 25, 35, 45. You don't have to remember the exact number. And days on ventilators, 5, 7, and 9 days on the ventilator for the duration. Makes sense? Sometimes you get asked from family how long you expect the patient will stay on ventilator. Never tell a fixed number. Because if you tell them a fixed number, if you intubate after, extubate after that, they will ask you why he's late on ventilator. Even if you extubate him earlier and he qualified for extubation, but he didn't do well and re-intubated, which is 14%, they will tell you you extubated him earlier than what he required. So never tell, because nobody knows, but these are from studies. We expect him, he has severe ARDS, we expect him, he will be at least on ventilator for 9 days, maybe shorter, maybe longer. So, because we don't know, every patient will differ. This is the data from this group of the patient that were studied. Make sense? Although this classification was never used in all the studies that we will talk about, except in one study, they use the 200 as cutoff. This is what I was telling you. What's not telling you the severity of illness based on the PF ratio only. If your patient with PF ratio 50, like our patient, on 0 PEEP, compared to another patient with the same PF ratio of 50 on 15 of PEEP, who is sicker? The one on 15 of PEEP, because PEEP will improve oxygenation. So PF ratio per se can tell you how sick he is, but not exactly how sick he is, because we don't know how much are the other vent settings. So this oxygenation index is something that will tell you more information about how sick your patient, and also you can use it in addition to the compliance that we talked about to follow your patient every day to see if he's getting better or worse. Here we will flip the PF ratio. So the PO2 will be in the bottom and FI2 will be on the top. That's why the lower in the oxygenation index, the better. Opposite the PF ratio, the higher the better. Normal PF ratio is 400 to 500, close to 500. Any of you, if I get ABG from you, what will be your oxygen in the ABG? 100. And how much if I2 you are breathing? 21. So it will be 0.2. 100 over 0.2, 500. Makes sense? So your PF ratio, normal PF ratio is 500. That's why the higher, the better. Here, because we've left the PF ratio in the equation, the lower the better, and normal is 2 to 3. And we will flip the PF ratio times 100 times your mean airway pressure. How do you get the mean airway pressure? Just look at the ventilator screen, will give you the peak and the mean. So you can use that if you have ADG every day. So if your patient PF ratio yesterday was 10, today he is 13, he is worse, sicker, right? Yesterday 10, he is 7, today he is better. So the lower the better. We said the normal is 2 to 3. And you can do your calculation. Your FiO2 is 0.2 and PO2 is 100 times 100 times your, if any one of us with healthy lungs or any patient with healthy lungs intubated, say for altered mental status, your mean airway pressure will be less than 10. Okay, so if you calculate that, you will get 2 to 3 normal oxygenation index. So when you reach 12, your patient is very sick. When you reach 30, this is what we call refractory hypoxemia. So oxygenation index, in addition to compliance, regardless of the vent changes you did, will stay the same if your patient stays the same. Compliance went up, oxygenation index went down, your patient is getting better. Compliance went down, oxygenation index went up, your patient is getting sick. Make sense? Any questions? Great. So this is how you look at your mean airway pressure. This patient has 18 mean airway pressure, his peak is 15, and his plateau is 19. So this number, that's what you use in the equation for the oxygenation index. This is how to calculate the ideal body weight, 5 kilos, 50 kilos for 5 feet for men, and 45 for women, and 2.3 for both. Here in the hospital, I'm not sure in St. Luke, in the vitals, they give you the height in centimeters. How about in St. Luke's? Same. How about over Lampard? Both. Both. Okay. So if you have the height in centimeters, to make it very quick, take 100 from the height for men and 105 from the women, will be a little bit higher than your ideal body weight. So if you have a man 175 kilos, his ideal body weight will be a little bit less than the 75 kilos, maybe 73, 72. So you can use the 75, will not change much. Woman, same height, 175, take 105, so she will be nearly 70 kilos, less than 70, maybe 68 or so. So this is a quick thing to calculate the ideal body weight if you want to get a question.
Yeah,
You got it? Okay. Okay, so again for ARDS, for the last time, tidal volume 6 ml per kg, ideal body weight. In the study, they called it predicted body weight, which is the same. They have used a different equation. 100% FiO2, you need to start with peak at least 8 for any patient with hypoxemic respiratory failure, and you need to use fast rate up to 35. In the study, they used up to 35. Rarely we use higher than 35 if needed. Patient is severely hypercarbic, and we are not able to correct the pH. So sometimes we go higher than if you have very sick people that are dying. So we are not looking at 28 days mortality, we are looking at few hours mortality. So we are trying to save them. So sometimes we do out of the studies that.
Do we start on P8 for every patient or just for RDS patient?
Every patient with hypoxemia.
Like if the patient for DKA, then in that case we're not starting.
If he's not hypoxemic, if he's hypoxemic, you start with. Make sense?
Mhm.
So the only time you start, right?
If apneic or abnormal breathing, we can start just on 5.
Yeah, if the patient is not hypoxemic, right? If you think your patient is morphine overdose and he was hypoxemic from the not ventilating, and his X-ray looks like normal, you can start with PO5. So things, especially if they will go away quickly, and you want to extubate them, so you need to wean the PEEP. PEEP cannot be dropped quickly. So you need to wean the PEEP. So, but you start PEEP of 8, get your EDG oxygen is very high, you can lower your PEEP to 5. Yes. No, we are talking about ARDS. You can go up to 35. This is your up to 35, not 35. So if your patient, your initial EVG is okay on 20, you can continue with the 20. Makes sense? So, but if you are hypercarbic, you can increase your rate up to 35. Not just the ARDS, there is a study in JAMA 2012 looked for people who are not ARDS. When they used small tidal volume, everything got better. So even non-ARDS patients, so rarely you'll need tidal volume more than 8 ml per kg ideal body weight. And unfortunately, there was a study nationwide, and we were part of that study. We had only 50% of people on tidal volume between 4 and 8, and the other 50% had more than 8 ml per kg ideal body weight. And this is not us here. Nearly every place had a good percentage of this higher tidal volume. So even non-ARDS, if you put them on higher rate, higher volume, more than 8 ml per kg ideal body weight, you will increase the lung injury, longer days on ventilator, more infection. So this study was a meta-analysis, and this showed if you use a small tidal volume, less lung injury, less mortality, less pulmonary infection, less hospital stay, less ventilator stay. What will go higher if you use smaller tidal volume?
Okay. Respiratory rate?
When you use small tidal volume in the AVG, what will go high? What will go low? pH, right? So CO2 will lower. So, and the study showed that people that used larger volume had lower carbon dioxide and higher pH, which makes sense, right? Okay, 65-year-old woman with IPF. This is the restrictive lung disease. We are done with the ARDS, 6 ml per kg ideal body weight. Fast rate to compensate for the small tidal volume, 100%, and at least 8 of peak when you intubate. Restrictive lung disease. Can you give me an example of restrictive lung disease? What's that? Interstitial lung disease? Obesity? You said something? Pulmonary fibrosis? Infiltrative disorder? Somebody said something there. Sarcoidosis? Okay. Extrinsic allergic alveolitis? Muscle disease? One more, because this will guide you to the setting.
Pleural effusion, we say?
Pleural effusion definitely will be. The first disease that we talked about is ARDS. So ARDS is restrictive lung disease, right? If your patient can do PFT, usually they cannot. You'll get restrictive lung disease. So really in restrictive lung disease, nearly similar setting to the ARDS, because ARDS is restrictive lung disease. So effusion, patient with pneumonectomy, all these are restrictive lung diseases, right? So this patient is IPF, admitted for acute exacerbation. She's a lady, setting 80% on high flow oxygen, 100%, height 5'6", and weighs 100 kilos, intubated by RT, and asking for vent settings. Which one you will select? What's her ideal body weight? 60. So what tidal volume you would use for her? If we think this is similar to ARDS, because ARDS is already a restrictive lung disease, so which answer will be the correct answer? D, tidal volume 360, 6 times 60, 360. Faster rate to compensate for the small tidal volume, 100% oxygen because she is very hypoxemic, and PEEP of 8 or higher. So nearly the same as the ARDS for restrictive lung disease, 5 to 7 ml per kg ideal body weight, tidal volume, 100% FI2. Fast rate, you can use the similar to the ARDS up to 35, and 8 or higher of PEEP when you start. ARDS and restrictive lung disease, you may have high pressures. So the small tidal volume also will save you from getting very high PEEP and plateau pressures because their lung is very stiff. Make sense? Okay, asthma, and same for COPD. So 20-year-old man with asthma admitted with exacerbation with no improvement, ABG 730, 50, 55, 24, on venti mask, 50%, intubated, initial vent settings. Okay, we talked about that briefly yesterday. Let me concentrate on that when we were reviewing the question for the vent setting for COPD. So we said asthma and COPD, the problem is in the lung parenchyma or the airway? The problem in more in inspiration or expiration? And you remember the example we used yesterday for obstructive lung disease? What was the example? Earthquake or fire, so and the room. So I don't know if anybody knows that there is a door there, right? So but this room can split into two, and every room can be a lecture, but because of our number is large, so there's some partition can go down. So there is a door there, and there is a door here. If we have the two doors open, this is a normal airway. If we have this door locked, and this door is the only door that we need to escape, we said we prefer to be 30 or 3. So let me say it in different way. Would you prefer to be 30 or 6 or 8 people? 6 or 8 people. Why did I pick 6 or 8 people? Because 6 to 8 ml per kg again, by the way, right? So this is your tidal volume and obstructive lung. So I will not use the earthquake example that I used yesterday. So I'll use fire today because we are on the ground floor. We'll not worry about earthquake. So if you have fire now, would you like God to give us longer time or shorter time to escape? Longer. So we need longer expiration time. Normal I to E ratio in the ventilator 1 to 2 or 1 to 3. So inspiration is 1, expiration is 2 or 3. So you may need to use 1 to 4, 1 to 5. So this will help you to allow the asthma and COPD to exhale the small tidal volume. Even if they are very tight with the small tidal volume you're giving to them, they may have difficulty exhaling that. You prefer slow rate or fast rate? Yes, slow rate, right? So fast rate? No, we talked about slow rate yesterday, right? Why did we talk about slow rate? We said, okay, if you have a rate 12 per minute, what will be your respiratory cycle duration? 60 over 12 will be 5 seconds. If you increase the rate from 12 to 20, what will be your respiratory cycle duration? 3. So you have 2 seconds reduction of your respiratory cycle, and always when you change the rate, this reduction will be from your respiratory time. So think 100 times before you increase your respiratory rate for patients with COPD, because you will shorten your respiratory time, and this may not be good. Make sense? So which answer you will pick for this patient? B, 7 ml per kg ideal by the way. Low I to E means long expiratory time, rate of 12, and peak of 8. Why peak of 8? Because your patient is hypoxemic. Yes.
Just a little bit confusing, but I have to watch the CO2, so I have to increase the rate at the same time. The less rate compared to the patient. Right?
So you're talking about faster rate will wash carbon dioxide, right? So and your carbon dioxide here in this patient is 50, and you want to wash the carbon dioxide.
I mean, if he has so many patients, so
we'll talk about that. We'll get to that. So why we don't use fast rate, even if your carbon dioxide is high and your pH is low. So we'll get to that. And we'll see what are the acceptable values. So everybody agrees with B for this patient. Same thing for COPD, same story. pH here is 713, 90. So your pH is even lower. And 90 carbon dioxide, 65, 32, all by PAP. So initial vent settings will be? Which one? Will be? Will be B, right? So it is B, right? So small tidal volume, 7 ml per kg ideal body weight. Low I to E ratio means longer expiratory time, rate of 12 on peak of 8. Make sense? Great. So it's not just the proper setting and leave. After you put the patient on the proper setting, small tidal volume, low rate, longer expiratory time, you need to look at this curve that we see here. I don't know if it's the green is showing from far, but you see this first breath. This is what we call the inspiratory, the flow time curve. This is inspiration above the line, then this is expiration. Be sure your patient exhales completely or nearly completely before next breath starts. So if he does that, you can go to your dictate your note or see other patient or go to your room to sleep and so on. If not, don't leave. So if you see your patient is doing the same thing, this is inspiration, but this is expiration, he does not exhale completely before the next breath starts, then you need to stay and do something, because this patient is keeping some volume from your 7 ml per kg or 8 ml per kg that you give him every breath. After few minutes, what he will get So pneumothorax, he will auto-PEEP first, then he can get pneumothorax. Make sense? So what can you do to help this patient to exhale completely? Decrease the respiratory rate. What else?
Decrease the volume.
Decrease the tidal volume. If you are on 8 ml per kg ideal bed, you can decrease it to 6. So increase the expiratory time. So instead of 1 to 3, make it 1 to 4, 1 to 5. PEEP will not affect the expiration. Then start the treatment. This will take longer time, but you need to start your bronchodilator, your steroid, and things like that to get things back. Make sense? So decrease the tidal volume, decrease the rate, increase your expiratory time. So all these things will make him exhale nearly completely. Because if not, he will retain a lot of volume. Then this will increase the pressure. You'll develop auto-PEEP, and with the auto-PEEP, you may have bulla that may rupture and get pneumothorax and tension. Great. So COPD and asthma, after you put them in the proper setting, don't leave. Just look at that flow time curve. And this is example how it looks like. So if you look here, your patient here in the middle curve. So this is pressure time curve, the one on the top. This one in the middle is your flow time curve. This one in the bottom is your volume time curve. So this is your flow time curve, inspiration above the line, expiration here. This patient is nearly exhaling completely, so he is okay before the next breath starts. If he starts the breath here, then you need to work on prolonging the expiratory time, lowering the volume, or decreasing the respiratory rate. Okay, so this is the last patient, the DKA. Patient with DKA, we talked about the cosmal breathing. Cosmal breathing, you describe it as deep rapid breathing. For the first few times, I don't hear the shallow rapid breathing. For some reason, every time I ask about the cosmal, they say rapid shallow breathing. It's coming from somewhere, but it's actually deep rapid breathing. So you need to simulate them, but not for a long time. So you start with 15 ml per kg or something like that, ideal body weight, and fast rate 35. So these patients are breathing liter and 40 breath per minute. I usually do not intubate DKA unless they have other reason other than the pH. Even with 6.8, I don't care. Patient is awake, can protect his airway. He's young, healthy lungs. He can tolerate a couple of hours until you correct his metabolic acidosis by insulin and fluids, right? So treatment of DKA is good. We have endocrine emergency lectures. So endocrine may have different opinion to avoid intubation. But we get calls from other hospitals. Oh, patient pH is 6.8. We want to transfer to you. I said, okay, so is he awake? He's awake. How old is he? He's 18. How is his X-ray? Wonderful. How is his oxygen? 100% on room air. Why do you want to refer him here? Just manage his DKA like what you manage DKA for anybody. I don't care. pH is 6.7. 2 hours, repeat the pH will be above 7. So just start the treatment. Treatment of the metabolic acidosis is not intubation. Patient is awake, can protect his airway, does not have lung disease. Just treat his DKA. Don't intubate. Okay. He's breathing 40. He should breathe 40 to compensate. So he's not like a person with COPD breathing 40 that you need to intubate, right? Or pneumonia that breathing 40 that you need to intubate. This patient is breathing 40 because he is healthy and he is trying to compensate. We said the lung is quick compensator, fast compensator. So this is what the lung is doing to correct for the pH. CO2 and the ABG will be 10 or 15. So this is normal. He's compensating for the hypercardia. Don't try to give him anything to suppress this breathing because he will do worse, right? And you don't need to intubate him if he's not. But don't keep him on this high setting for a long time because there was, I think 2005, a kid, 5-year-old had DKA, and they put her on this high setting and she got alkalemic pH and she died from cerebral edema. So similar when you give bicarb to this DKA. So you can develop cerebral edema. So no intubation for me, no bicarb too. You may hear something different, but for me, I don't give bicarb, regardless of the pH, as long as my patient is doing okay. Okay. Some even literature, not they tell you bicarb if pH is below 7, but I usually don't give bicarb for these people at all. Just correct their metabolic acidosis. Makes sense? And you don't have to. They don't get tired quickly. If your patient is very tired and very lethargic, you may need to put them on some even non-invasive pressure or intubate them or something. But really, patient young, healthy, can compensate. He can tolerate 2 more hours. He's in this situation for 15, 16 hours at home, maybe longer. Make sense? Start fluid, start insulin. This is what you need to start. If you intubated him after 2 hours, get another ABG. Usually after you intubate anybody in 30 minutes, you need to get ABG. First ABG, 30 minutes after intubation to 1 hour. So to get a baseline house you do, then modify your vent setting. For these people, maybe after 2 hours, I get another ABG or even VBG to look at the pH. And if pH is 7 or higher, you slow him to 8 ml per kg and rate him at 20 or so. Any questions about the initial vent setting? These are the most common diseases that you will see in the intensive care. So ARDS, obstructive lung disease, asthma and COPD, restrictive lung disease, and rarely you will intubate patients with CKD. Any question about this first part? Okay. Let's move to the problems that you may be called about as senior resident in July. Anybody knows the schedule that has ICU in July? You don't have the schedule, so still a surprise coming. Okay. So this will be very, very new. You are now, you have the resident, senior resident that you will call. But in the ICU, you have also the fellow on call. So you can call the fellow to discuss anything, don't be shy. So, but you will feel that you are by yourself. And the 2 things that scare you is ICU management and when you are the wreck, the code blues. That's why the last hour and a half would be the ACLS part. So these are the 2 things that scare residents initially when they get ICU rotation early. When they are wrecked, they get code blue. So these are the 4 problems that we'll talk about. Hypoxemia. And I want you to use the word hypoxemia, not hypoxia. Hypoxia is tissue hypoxia. Hypoxemia is what you get with the ABG and the pulse oximetry, hypoxemia. Okay? So hypercarbia or hypercapnia, hypotension from vent settings, high airway pressure. Let's start with this case, 55-year-old man with bilateral MRSA pneumonia, intubated, and vent settings, FiO2 50%, PePO5 rate of 12, on tidal volume 500, oxygen saturation is 95%. The nurse called because he had worsened hypoxemia later on. So in the morning, and usually patients get sick more at night. So they're not doing that, but you feel that because you are by yourself. So in the morning, you have senior residents, you have fellow, you have staff, so with you, so you feel at night they are getting more problems because anyway. So this patient was doing well in the morning, 50% of I2 and 5 of PEEP, and he is sacking 95%. Now the nurse called you at 1 o'clock in the morning, patient is sacking 80%. What should you think about? What's your differential diagnosis? Let's start with that. Pneumothorax, mucus plugging, developing ARDS, worsening pneumonia, tube displacement went to the right main stem or went above the port, pleural effusion. If you develop pleural effusion quickly, what should you think about? Anybody got the patient who had the pneumothorax? So you see this lady came from other hospital, had CT abdomen for what was considered abdominal pain, had 0 effusion in the CT abdomen, more hypoxemic, more effusion. Hemoglobin was 13 on admission, went down to 7. What's your differential? Pneumothorax, right? So your hemoglobin is dropping quickly and your effusion is developing quickly. So between the CT abdomen and the next X-ray, few hours. And patient INR5, hemoglobin 13, 11, 7, 9, 7. So nothing else. So we placed the chest tube for this patient and she drained pneumothorax. Make sense? So this is what you need to think about, rapid accumulation of fluid. Can you get tension pneumothorax? Yes. Can you get tension pleural effusion? Yes. If you have fluid, same thing for the heart. You can get tamponade with small effusion if it accumulates quickly. So bleeding into the myocardium, it is small, but patient can get tamponade physiology. It's not volume, it's how quickly it accumulates for tension, pneumothorax, and for tamponade. Make sense? So what else? She's on DVT prophylaxis, but she can get PE. Even if on DVT prophylaxis, you can get PE. So these are the things, mechanical problems, so ventilator issue. So 5-6 years ago, I don't know if anybody saw Bell, the RT. He is working PRN now. He retired with the COVID. We brought him back as PRN. He was the second person in the RT department. And we had a patient on BiPAP. And she was on 40%, setting 92. She's severe COPD, 92%. Then suddenly she's 80s. We increased the FI2 from 40 to 60 to 80 to 100. She's still in the 80s. So we called the RT to bring ventilator to intubate her. And RT came. What did he say? We don't need to intubate her. The oxygen is unplugged. So she was on BiPAP and room air. Somebody pulled the machine, unplugged the oxygen. So what he did, plugged the oxygen, sat 92% in few seconds. So you should think that that's why nurses, before they call you, they disconnect the patient from the ventilator and bag them to rule out any mechanical issue on ventilator. And also they suction very well to rule out any mucus plugging that was mentioned. Make sense? Okay, so these are the things that you should think about. These are the differential diagnosis. I think we didn't miss any. Okay, what should you do? X-ray.
Examination.
Yeah. late. So what you need to do, you need to go and assess your patient, right? You can order chest X-ray, ABG, that's fine. So you can order, you look with the ultrasound. If you're thinking pneumothorax, you can look with the ultrasound to see if there is any pneumothorax. This is the quicker mode if you're good in ultrasound compared to the X-ray. Okay, now let's talk about how can we improve the oxygenation. What do you think you can do to help this oxygen? Remember, this patient was in 50% FiO2 and 5-OT. The nurses bagged her and suctioned her very well to rule out any mechanical problem in the ventilator. And you suction, you got your ABG, she is hypoxemic. Is there any disease can cause hypoxemia and the ABG doesn't show hypoxemia?
Yeah, carbon monoxide poisoning,
Not carbon monoxide. Carbon monoxide will give you the opposite. The cousin of carbon monoxide poisoning is SAT 85%, patient is blue, and the oxygen in the ABG is 100. Methemoglobinemia, right? So this is also if your patient is severely vasoconstricted and you are not able to pick proper oxygenation. These are the situations that really you need it. If your patient doesn't have that, you don't expect that. What can cause methemoglobinemia in the hospital? Like lidocaine or imicaine. This is one of the most common causes. So on the board, they tell you patient went for EGD, they used benzocaine or lidocaine or something, or same thing for bronchoscopy, we use lidocaine for numbing, local numbing of the above the cord and below the cord. So then they tell you patient is sacking 85% blue and they give you EBG with normal oxygen. So this is patches. We use lidocaine patches a lot in the hospital. So think about that as a cause of methemoglobinemia. Anyway, so we ruled out any of these etiologies. We think this patient is worsening pneumonia, developing ARDS, and we want to work on helping his oxygenation. What should we do?
Increase speed.
Increase speed.
Increase FiO2.
Increase FiO2. I would start with FiO2 first. Why? Because it will work faster than the PEEP. PEEP may take some time to help to recruit it. So he is on 50%. You said increase PEEP. Would you like to go to 51%?
No, 60.
I increased the FiO2, right? 50 to 51, I increase it. So you need to be specific in ICU. Don't leave it to the RT, right? So 50%, patient setting 80% about to code. You go to 100%, right? Acute situation, go to 100, right? So you don't have time. You need to be as quick as you can. PEEP was 5. How much higher PEEP? 8. Okay. So you want to go to 8? I would go 2 at a time, and I will tell you why I go to 2. I will not the VAE. Yes. So I can De-escalate the FiO2 quickly if patient gets better. But I cannot wean the peak quickly if the patient does not get better. Make sense? In the acute situation, patient is about to code, you can go to the 100%, go up with the PEEP as much as your patient needs. But you have to document that. Any event changes in the ICU should be documented. Because till July, I review all the VAs and I don't find good documentation. Actually, you have to put order or change the band setting order, not just RT communication, because this will tell me why, and you have to pick etiology why this happened, but you have to document. If you are on call, you have to document any increase in the band settings. One line, band settings increase from FiO2 of 50% to 100% because of desaturation down to whatever. So just tell me that you did it for correct reason. So if your patient is not in an acute situation, you can go up by 2 on the peak, go up by 19 on the FiO2. This will not be VAE like what I showed. So increase FiO2, increase the PEEP by 2, gradually up. If you want to go quicker, you can go quicker if you need. What else? Will not help. So increase the eye time will help. So increase the eye time, because when you increase the eye time, you keep your 100% oxygen in the alveoli for longer time. You allow more diffusion of the oxygen to the capillaries. What else? Repositioning. What repositioning you are talking about? So when do you select one side down if you have one lung is worse than the other? Which lung you put down? Which lung you put down? Which lung you put down? If I repeat the question, then the answer is not correct. Which lung you put down? Good lung down, not the worst. I'm hearing the worst 5 times, and I'm repeating the question. If I repeat the question, then I didn't like that. So just switch to the other answer immediately. Next, the good lung down. Why is that? Oxygenation, blood flow goes with gravity. So if you put the good lung down, more perfusion will go to this lung and will give you better BQ match. Make sense? What disease you put the worst lung down? Only one disease. Effusion. Not effusion. Yeah. Bleeding, hemoptysis. If I did one mass biopsy from the left side and patient has hemoptysis, I put the hemoptysis lung down. Why? Because how do we die from hemoptysis? From hypotension, correct? Incorrect. From anemia, correct? Incorrect. We die from asphyxiation. The lung drowns, the lung gets drowned by the blood. So you put the bleeding lung down, so you keep the blood in this lung, let the patient breathe with the other lung. So the only situation you put the bad lung down is bleeding in the lung. Make sense? To keep the blood in this lung doesn't go to the other lung. Make sense? So if you have any patient with hemoptysis, you look even at the X-ray or CT and you see one lung has masses or infiltrate or something like it, empirically put this bad lung down if he has hemoptysis. If he does not have hemoptysis and he's hypoxemic, put the good lung down. Then proning. Proning also will improve the mortality for these people. Proning will improve the mortality, and we'll talk about the studies that show proning. What else? So we talked about increase FiO2 in the acute situation, go to 100, gradually increase the PEEP, increase the eye time. You can also add an inspiratory pause for half a second after inspiration. So patient breathe for half a second, does not exhale immediately, will stay half a second in full inspiration before he breathes. This is a modality that you can do on the ventilator. Positioning, good lung down, unless you have hemoptysis. Proning. What else? NO or prostacyclin, they will work the same. Prostacyclin is way cheaper. We have prostacyclin here, and I think in Lux we have prostacyclin. Anybody is MedPed? You may have NO in the pediatric side. It's way expensive, like maybe 300 versus $10,000 per day. So, but the kids, they can pay more for the kids. So most likely you'll see the NO in pediatric. I had it in my fellowship training. So It comes like a small container you connect to the back of the ventilator. So what is the thing that people said it may not help, and I told you don't let the fellow hear you? No. Call the fellow. You need to call the fellow way early. And you need to ask the fellow to come. You'll be senior next year. You need to ask the fellow to come. If you are here on call till July 1st, and you have patient with hypoxemia and you need to call the fellow immediately once you go and assess the patient. So, and if you need the fellow to come, if patient is not improving, you need the fellow to come. So tell him I need you to come. What else the fellow can do? Not bronchoscopy, unless you have significant mucus plug. We said we ruled out any of the other correctable etiology. If you want to call that attending anytime, you're welcome to call that. I have 5 more days on the ICU. So I'm switching to 100% sleep on August 1st. So, but definitely you can call that attending. If you have issues with the fellow, you want him to come and you have resistance, you have to call that attending, right? This is very important. So we are on call. So the ICU attending for that week is on call for the ICU that week. So paralytic, another thing that can improve the oxygenation is to paralyze the patient. One study showed improved mortality with paralytic. One study showed no improvement in mortality with paralytic, and I will show you that. So another mode, what we call APRV. What's APRV stands for? Okay, that's fine. So it stands for airway pressure release ventilator. Airway pressure release ventilator. This APRV mode improves oxygenation, but no studies aim to look at mortality. So it does not improve mortality, but may improve mortality. We don't know. But there is no study that showed or aim to look at the mortality. So it may improve oxygenation. Questionable, the Flolan, prostacyclin, and NO, would they improve oxygenation, but they don't improve mortality. So go and assess the patient, rule out any correctable etiology, have correctable etiology corrected. Call the fellow, increase the FiO2 in acute situation to 100%, increase the PEEP gradually, increase eye time, respiratory pause, put lung down, proning, paralytic, APRV mode. And if your patient does not get better, what should you do? If you are in loops, you can do ECMO, right? If you are here, if your patient can't tolerate, transfer to loops or to get ECMO. If he can't tolerate, most likely in this situation, they may not tolerate the transfer. I transferred one patient for ECMO. She was a pregnant lady, and I called OB and they delivered her. And she actually got better. After delivery, we had the chance to start other things. And OB were somewhat worried, so they requested to transfer for ECMO. She went to loops, she tolerated the transfer, but she did not get ECMO because she was already getting better. So, and the big percent of people that are transferred from hospital to hospital for the ECMO, or even you transfer from ICU to the CDICU and loops, they may not get it. So they may just tolerate it, but ECMO is an option. We used to use a recruitment maneuver and what we call oscillator. Pediatric, you would use oscillator because data showed improved outcomes for ARDS and pediatric, but 2 studies in the same journal showed no benefit compared to 6 ml per kg, and 1 study showed worse mortality compared to 6 ml per kg. So these are the things that we can do. Increase the FiO2, call the fellow, increase PEEP, position good lung down, proning, increase eye time, respiratory pause, inhale prostacyclin, same for nitric oxide, paralytics, APRV, and these 2 things are out. Although in the guidelines 2021 for the patient with COVID ARDS, they recommend recruitment for these patients. Although data showed that recruitment may worsen that. But if you have nothing to do and your patient is dying, you can try the recruitment, but we don't do it. High frequency oscillator, we don't use anymore. And then the last thing is ECMO.
What do you do?
How would we do what?
Recruitment?
You don't even, I don't want you to even to know about it. This is a fellow job and a last thing to be done. So fellow should be here from 2 hours ago, right? So even in there are two ways to do the recruitment. You can go to very high peak. So your peak is say 8, you go to 30 and leaving there for 40 to 60 seconds. The other way that they don't recommend to go gradually. So 8, 10, 12, 15, in a few seconds you go up. So they call it stepwise in the peak. And this, they didn't recommend that. They want to recommend it. But what can happen with your patient going up to peak of 30 for 60 seconds? Pneumothorax, you need to put a chest tube. So patient is already severely hypoxemic and you get a pneumothorax. Or hypotension, you decrease the return. Like tension pneumothorax, right? So you get hypotension. You should have outline and should have blood pressure monitoring. If you see the blood pressure going down, then you have to drop the peak quickly down. So that's why recruitment is very risky, and the data showed it may not improve mortality, even may worsen the mortality. So many things to be done before you say patient is difficult to oxygen. Your oxygen goal for ARDS on ventilator is 88 to 95. So if your patient has ABG this morning and his oxygen, your 55 to 80 in the ABG, your ABG shows 58. You are at your goal. You don't have to change anything, okay? But if your patient is 58 today and yesterday he was 70 on the same setting, we need to look why your patient got more hypoxemic. Make sense? But you are at your goal. Same thing, your patient is 89% on the ventilator with ARDS. You don't need to do anything. You are at your goal, 88 to 95%. But if your patient was setting 95 and now he's setting 89, you need to look why he's doing that. Is he developing pneumothorax? Is he volume overloaded? So you need to assess why his oxygen saturation dropped. But you are at your goal. Exceptions will be pregnancy and sickle. You need 95%. Another guideline says that for CVA, and most of the people other than ARDS, you want 94%. And if your patient is COPD or any hypercardia, 88 to 92. And if your patient has COVID, your goal is 90 to 96 seconds. What's the safe FiO2 that we can swear about? Can you swear? 21. Yeah, 21%. Everybody can swear about that. But people think 40 to 50% is okay, and some people think 60% is okay. So really, you don't have to reduce your patient FiO2 to 30%. I usually reduce them to 50%, 60%, and start lowering them. 100% is injurious. Fluid management, this is an important thing that we didn't mention that may improve your hypoxemia on the long term. How much fluid you drink every day? 1.5. 3 liters. So something between 1.5 and 3 liters, 2.5 liters, this is average. If you have your patient is getting 5 liters every day and he's making 2 liters urine, you think he's doing okay. He's not doing okay. Where are the extra 3 liters? Okay, so number one diuretic in the ICU is Lasix. Decrease the fluid intake. So if you reduce his 5 liters to 3 liters, how much you diurese him? 2 liters, right? So this is important. So the diuresis is comparison between an I's and O's, right? So before you start any diuretic, look at your M. Is your M too high? Then you need to reduce it. Make sense? Okay, so this is a study in 23 regarding proning. And this study showed improved mortality with proning, but this not only proning, it's early proning. And they proned people 16 hours. This was the goal, but they found that they proned them in average 20 hours. So in average, they were prone 20 hours and 4 hours on the back. This study did not use proning bed. There are 2 videos you can watch on up to date for the proning process. There is a shorter video from the study, this study, and there is a longer video from Rush University. This video from Russia is more detailed and shows the proning. This video from this study, in 5 minutes, they prone the patient and put him back on his back. So it is important to reduce mortality 28 days and also 90 days, significant reduction in mortality. So the only complication that differed between the two was more cardiac arrest in people who were not prone. So even proning reduced the cardiac arrest. It's early proning. So when did they start proning? Patient with PF ratio less than 150. That's why I'm telling you the 100, 200, 300 of the modified Berlin is not used in the studies that showed benefit for ARDS. They use completely different. Most of the studies use this setting. PF ratio less than 150 or FI2 60% or higher, people 5 or higher. This when they enter. So it's early proning. You see the early in red? Don't wait until the patient, you do everything and he's not getting better, then you prone him. So it's early proning. Many people will see this patient, say he's doing fine. He's not check out from fellow to fellow, from resident to resident patient. Nobody is very second ICU. He is on 5 of PEEP and 60%, and PF ratio is above 150. So he's okay, right? But this is when you need to start the proning to show the benefit. 11 randomized controlled trials looked at that only. That's why I'm telling you, you have to remember your name. Only the patients who were prone and were on 6 ml per kg ideal body weight showed improved mortality. Any patient who was not on 6 ml per kg ideal body weight did not improve in the mortality. Theories, you improve the BQ matching, you improve the secretion drainage, you improve the inhaler delivery to all parts of the lung, less lung volume, more dependent. So the anterior part of the lung is smaller than the posterior. So when you are prone, if fluid accumulates there, this is less lung volume. Also, the heart pressure is taken away. The abdomen, if you use the proning bed, the abdomen, they open the part of the abdomen, so the belly will be not compressing on the chest. So all these are theories why things get better with the proning. Contraindications, major ones are patient with unstable spine, somebody was fractured, came from trauma or something. Somebody had recent trick, although I can discuss that with the surgeon who did the trick, and we can be more cautious and we can prone him, but this is one. Pregnancy, patient is dying, I may discuss with OB, I may need proning bed, so I will not have the abdomen compressed by the regular bed. But all these contraindications you need to discuss with the other specialty if we can prone them or not. When to stop proning? After they are on their back for 4 hours, you assess ABG. PF ratio is 150 or higher, 60% or higher or less FI2, and PEEP 10 or less, you can stop the proning. Though this is what they use in the study. Although if you look at these, they are worse number than the numbers they prone them with. So, but this is what they used. 4 hours on their back, they assessed, and if they meet this criteria, they don't prone them anymore. This is a study for neuromuscular blocker in 2010. They used the same criteria to start the neuromuscular blocker. They used cisatracorium for the first 48 hours continuous drip and also improved mortality. Another study in New England later on, 2019, showed no improvement in mortality. But in this study, their criteria was sicker patients. So they used patients with PEEP of 8 or higher, not 5 or higher. And the PF ratio is the same, less than 150. And this study showed no difference between proning, between neuromuscular blocker and non-neuromuscular. This study of a steroid, I'm sure everybody heard about the study with the COVID. So sometimes you use 8 milligram IV, not 6. Although the study that showed improved mortality in COVID is 6 milligram IV, right? But here in the US, we have to use 8 milligram IV. Why? Anybody heard about this before? No? If you use for COVID steroid IV, if you use oral, 6 milligram is okay. But if you use IV, you have to use 8 milligram. The study that showed mortality benefit with the COVID 6 milligram per kg was done in Europe. Our IV steroid here has different salt and whatever equivalent to 6 milligram IV steroid in Europe is 8 milligram IV steroid here. Okay, that's why if you use IV, but if you use oral, 6 is okay. Then many patients, they're not getting better, or so from the beginning they're in the ICU, they have ARDS. We use the 20 milligram for 5 days and 10 milligram for 5 days. This is coming from this study that was done in Spain, not the best study, but they used the criteria 200 for this patient, and they showed improved mortality. So they put them, if they are on 200, if they are on PF ratio 200, they started the and 50% FI2 and 10 of P, they started the 20 milligram for 5 days and 5 milligram, 10 milligram for 5 days. So 20 for 5 days, 10 for 5 days. And this data showed improved mortality and more ventilator-free days. Now the best study was stopped early because they couldn't recruit the number they want, but they recruited 80% of the number they want. This is the Flolan order set. So you cannot order it as a resident, so you have to call the fellow to order it. And Flolan is based on ideal body weight. Important thing when you order the Flolan and you want to change the rate, you have to change the rate in the order set, but you have to communicate with RT that you are changing the rate up or down. First time we used the Flolan, we didn't know that the changing order doesn't go to the RT who changed the rate of the syringe. So we wean the patient from 30 to 25 to 20 to 15 to 10, and we said, okay, we need to stop the Flolan. Then RT said, oh, the patient's still on 30. We are 4 or 5 days reducing the Flolan, but nobody communicated to the RT to reduce it. Because pharmacy will send the syringe with the same concentration, regardless of the amount you want. But the rate of the infusion will change lower or higher by the RT when you want to go down or up. Make sense? Great. APRV, I'll go quickly for the APRV for the sake of the time, but APRV is simply some pressure mode, pressure targeted mode, but has two pressures, as if it's two CPAP pressures. And we call them high and low. We don't call them inspiration and expiration. And I'll tell you why. So high and low. So when you order, you have 4 parameters you need to order. Pressure high, pressure low, time low. Make sense? Great. So APRV, we don't call them inspiration and expiration because the patient can breathe in and out when he is on the high or in the low. Make sense? We also, although the low pressure will be 0, no PEEP, but we want them to auto PEEP. So this is the only situation that we want them to auto PEEP. So to make it easy for you, do that with me. Everybody, follow me. Take a deep breath. Fill your lung. And exhale. Don't exhale completely. Inhale again. Fill your lung. And exhale. Inhale again. And so that's why this is the APRV. Improves oxygenation. No studies looked at mortality. So we don't know if it will improve mortality or not. But no studies looked at mortality. But definitely will improve oxygenation. What will worsen? Carbon dioxide. That's why it is contraindicated in patients with COPD and asthma. Because your expiratory time, which is the time low, is very short. We start with 5 seconds time high and ½ second time low. Pressure low is 0, no PEEP. And pressure high, we said what plateau pressure is dangerous above 30. I usually start with 30. A lot of things, but to make it simple, time high 5 seconds, time low ½ second, pressure high 30, pressure low 0. But we start to lower the time low to allow the patient to auto PEEP, because you don't want them. What's the mechanism it functions? It's mainly recruiting alveoli, because you are using very high pressure. Most of the time your patient pressure will be close, very close to the pressure high. Okay, your mean airway pressure will be here. So you are using very high pressure. You open some alveoli. If you go to pressure 0, what will happen to these opened alveoli? Will collapse. Then you open them, then collapse, then open them again, collapse. We know from a lot of animal studies that this inflation deflation of the alveoli cause lung injury. That's why we want to inflate them, keep them inflated, so we don't allow them to exhale. completely. So I have few more slides, but this is what we talked about, and I will not.
Is it a kind of principle that works that with recruitment?
This is recruitment, but it is a mode of recruitment that will stay, and you are at a certain level and you allow release, so your venous return will get better. So, and what the difference between the high pressure and the low pressure? Wash carbon dioxide. We don't prefer to paralyze these people because this panting thing that I told you about, wash carbon dioxide. So if you paralyze them, they get higher carbon dioxide. How would you improve oxygenation and how would you improve carbon dioxide? So if you, to improve the oxygenation, you need to increase FiO2. So if your patient is not on 100%, you can go up on FiO2. You can prolong the pressure high, which is an inspiratory time. So the time high, you can prolong it. Also, you can increase the pressure high if you are below 30. So these are things: increase FiO2, longer time high, higher pressure high. These are things that will improve your oxygenation in the long term. You can shorten the time low, but be careful about that, will worsen your carbon dioxide. Carbon dioxide is high, you want to wash it. What can you do? You can increase the pressure high, because we said the difference between the pressure high and the pressure low will give you how quickly the flow when they exhale. So they get larger volume out. You can reduce the time high, but be careful, when you reduce the time high, you may worsen the oxygenation. You can prolong the time low, but be careful, when you prolong the time low, you may have complete collapse of the alveoli that you refer. So to improve hypoxemia on APRB, increase the FiO2, increase pressure high, increase time high. To improve acidemia or from hypercarbia, only if your pH is below 7.15, correct metabolic component if possible. Avoid deep sedation. If your tidal volume is less than 6 ml per kg, increase your time low and reduce the time high, but be careful, this will worsen your hypoxemia. You can increase the pressure high if possible. So if you really need to make the time high lower and you have place to increase the pressure high, you can increase the pressure high and reduce the time high, so you don't get significant changes. PAE, we start with VAC. 2013 CDC definition of ventilator-associated pneumonia depends on hypoxemia, and they define the hypoxemia as the VAC. What's the VAC? Ventilator-associated condition. If your patient needs or increase of PEEP of 3 or more, or 20% FiO2. So sometimes you will find me increase the FiO2 from 50 to 69. Weird number, right? 69, why not 70? Because 70 is VAE, 69 is not. And it is a reportable thing. Make sense? So if your patient is setting 89% and he's on PEEP of 5 and FiO2 40, you can increase the PEEP by 2 to 7 and increase the FiO2 by 10. You are not VAE. And instead of increasing the PEEP by 3 or increasing the FiO2 from 40 to 60 and not changing the PEEP, because you will be VAE if you increase the PEEP by 3 and stay for 2 days. That's why we have RT, Renee, she does that every day. We'll review all the vent settings. If you have any patient qualifies for VAE, she may ask you, can you lower him for 1 hour? Because PEEP of the day is the lowest PEEP for 1 hour. So if you up him from 5 to 8, she will tell you can lower him to 7 for 1 hour. If your patient can't tolerate that, you can do that. If not, tell her no, patient is very sick and I'm even going higher. Make sense? So if you have VAC, and this is a board question, so ventilator-associated pneumonia is based on worsened hypoxemia. This is the first step to evaluate. If you have VAC, you look for infection-related VAC, IVAC. And if you have IVAC, you look for possible or probable DAP. Okay, hypercarbia. 50-year-old man with COPD exacerbation intubated. Vent settings, I will answer your question. 7 ml per kg ideal body weight, respiratory rate 12, FiO2 60%, and PEEP of 5. ABG 730, 65, 132. What you don't like in this ABG? Carbon dioxide is 65, right? And this causing your pH to be low. What can you do? I will give you options that may help your carbon dioxide wash. Which one you think will help? You can pick more than one answer if you want. A, B, A and B. Okay, let's do A. So his rate is 12, we increase him to 20. 30 minutes later, we got ABG. What happened to the ABG? Nothing. We doubled his rate, right? But nothing happened. Why? 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 No, 30 minutes is very enough to wash carbon dioxide. Why? Why? Okay, your vent rate was 12. Patient was breathing 25. You upped his rate from 12 to 20. What happened to the patient? Nothing. So before you increase your rate, you need to check if your patient is controlled or assisted. He was assisted, and you didn't check that. Very simple. Smiling. Okay. He's nearly laughing. So yes, you need to check that. You wasted your time. They will call you again with the ABG, wake you up from sleep, and you wasted the RT time, and you did nothing to the patient. Okay. So this increased the rate to 20 and increased the volume to 10 ml per kg. So we combine option A and B. Patient now is hypotensive. What happened? So we call that auto peeping, right? So what are the other things? What happened? Why this patient got hypotensive with this larger volume and faster rate?
Did we put him on controlled and increased paralysis?
Pneumothorax, give me a better word. Tension, hypotension from pneumothorax, tension, pneumothorax. So these are the two things that can happen for these vent changes, right? So two board questions. Treatment of tension pneumothorax is needle. Where do you put the needle? Second intercostal space, Mittler-Becker line, right? Right or left? Wherever the pneumothorax is. So. There are some situations that patient during code we didn't know what's going on when we needed both sides because we were thinking pneumothorax and put chest tubes immediately. So but you need if you know what side has pneumothorax, you need them. Okay, so auto peeping, hypotension. How do you treat him? Another board question. Disconnect the ventilator from the ET tube. Let him exhale and empty his chest. While he is exhaling, he will exhale for a long time. Then while he is doing that, return your vent settings to the initial settings, right? So A and B were wrong answers. Do you want to see the options again? What I didn't like in this ABG that his oxygen is 100 with CO2 retention. I should lower his FiO2. I am okay with 730 pH for COPD. This patient is chronically pain. You remember the acid base yesterday? Have to calculate his baseline. So this patient is chronically pain. So he's nearly at his baseline, right? So don't rush.
The chronic retention, shouldn't the pH be normal?
No.
No.
We talked about every 10 will lower the pH, chronic is 0.0, right? We are okay with 715 pH for ARDS, 7.2 for COPD. If you try to normalize carbon dioxide, you are harming your patient. So 715 pH for ARDS is okay, except if you have these three exclusions or exceptions. Cerebral edema, because acidosis will worsen the cerebral edema. Severe pulmonary hypertension, because acidosis will cause vasoconstriction. So acidemia and hypoxemia are not good for pulmonary hypertension. Somebody is coding with PA arrest, you need to correct the pH. Make sense? So this is what we call permissive hypercardia. Did you get my question? So I don't want to normalize and I don't want to change things as long as my pH is 720 for COPD, regardless of this. CO2 is 105. I don't care. pH is 725. This patient is chronic retainer, maybe baseline is 80. right? So don't try to normalize or lower as long as your pH is 7.2 or higher. Because if you try to normalize it, you harm them. You can get autophagy, you're going to get tension pneumothorax. Got it?
The RT team in here and
I don't care about RT.
they are doing the ABG, and then when they found the patient is hypercapnic,
Then you need to talk to the RT.
Yeah.
And if they call you, tell them I'm okay with that. So don't change, don't follow the RT. That's why we are learning here. Then I should give the lecture to the RT, right? Prophylactic lectures. Actually, I give lectures to RT, and we have RT symposium, and I gave them a lot of lectures about that, but we stopped doing that with the COVID. They may come back, usually some wonders. But anyway, so don't let RT drive you. And RT shouldn't change the vent setting without order from the physician. Another thing that we talked about yesterday, avoid complete correction. Somebody with baseline 70 carbon dioxide, don't correct him to 40. His 70 baseline carbon dioxide and his bicarb to compensate for that chronically, 310 times 4, 12 plus 24, 36. So patient has CO2 70 chronically, and he came with 100, you correct him to 70. If you correct him to 40, what will happen to the 32 bicarb? pH will become alkalemic. Kidney will say, oh, I don't need that much bicarb, so we'll get rid of the bicarb. And you remember yesterday, sorry for the people who are going to nephrology, kidney is slow to compensate, right? Not like the lung. So if you trial him during this 30 minutes trial, his CO2 will go back to 70, but your bicarb is 24. You get the ABG at the end of the trial. What happened? pH is 715, because he had the 30 rise acutely with no bicarb to compensate. Then he failed the trial. Did he fail the trial? He did not fail the trial. We failed the management, right? So this is our issue, and it's a board push. Make sense? Too much CO2, too much oxygen will worsen your carbon dioxide. This is very common in the ED. Patient comes with 80% saturation on room air. They put him on non-rebreather. They get ABG. CO2 is 120. They intubate him. What happened? They gave him too much oxygen. So patient with expected CO2 retention, you start with 2 liters of oxygen titrate up for SAT 88 to 90%. Make sense? Don't start with non-rebreather. If your patient is very hypoxemic, you can put him on non-rebreather, stay with him, SAT cross the 90, lower his oxygen. But if you start him with 2 liters and escalate, if you think he's still taking exacerbation, obesity, hypoventilation, neuromuscular disease, you don't want 100%. 100% will increase your carbon dioxide, or too much oxygen will increase your carbon dioxide. Look at this. If you have a bulla, the bulla is hypoxemic and hypoventilated. What will happen from the hypoxemia? Will get vasoconstriction of the capillaries supplying this bulla. So this blood flow will go to this bulla as a protective mechanism from our body. Hypoxemia will cause vasoconstriction of the capillaries. If you give them too much oxygen, this bulla will be oxygenated, but still hypoventilated. So more blood will go because not hypoxemic anymore, the capillaries will vasodilate. So you worsen your VQ MASH, and this is important thing. Will increase your carbon dioxide because you will increase what you call shunting. Blood will go to area that's not vented. Second, etiology, what you call Haldane effect. Haldane describes something that happens in this lower square here. This happens normally. So your blood in the lung will get oxygen, get rid of carbon dioxide. In the tissue, we'll do the opposite. We'll give oxygen and take carbon dioxide from the tissue. This is based on your pH and acidity and a lot of things. If you give too much oxygen, when you measure ABG, you are measuring oxygen and carbon dioxide dissolved in the plasma, not attached to the red blood cells. What measures the oxygen attached to the red blood cells is your oxygen saturation. But when you measure the ABG, you are measuring the carbon, the PaCO2, and the PaO2 is the oxygen carbon dioxide dissolved in the plasma. So when you give too much oxygen, it will compete with the carbon dioxide on the hemoglobin. Will release more carbon dioxide from the hemoglobin to the plasma. So you worsen your PaCO2. Oxygen, you remember when we have somebody with pneumothorax and small and we don't put chest tube, we put them on some oxygen to help the absorption because oxygen is quickly absorbed. So if you give them too much oxygen, it can cause atelectasis because the oxygen in the alveoli will be absorbed quickly, can cause atelectasis of the alveoli. Oxygen, did you hear about patients tell you, I use oxygen when I walk because I feel better when I walk. And you walk him, he doesn't qualify for oxygen. He refused to stop his oxygen. He feels better. Yes, oxygen can make them feel better. And also it is a soothing thing, so people can sleep more. Also, if you give them too much oxygen, 10% of people, their chemoreceptors feel the hypoxemia, so they hyperventilate. But they don't feel the high carbon dioxide. Carbon dioxide is 100, they don't feel it. So they don't have hyperventilate. When you correct the hypoxemia, if your patient is not intubated, they may hypoventilate. Even if your patient is on ventilator and you have a rate of 16 and he's breathing 25, too much oxygen will let him breathe slower. So no too much oxygen, SAT 88 to 92% for patients with CO2 chronic retention. Acute changes in the pressure. This is the last problem we'll talk about. 60-year-old with COPD exacerbation, intubated, sedated, was doing okay in the morning. Peak pressure 20, plateau pressure 15. You remember what I told you. At 3 a.m., they called you because his peak pressure went to 50 and plateau pressure went to 24. We had similar question, the pre-test. All these can explain that except. So we have increase in the peak and increase the plateau. Okay. So ET tube move to the right bronchus. Any other answer? Worsened airway obstruction. So E is the correct answer. But this is airway problem. If your ET tube, that's 500 tidal volume, ventilating 2 lungs, when it goes to the right lung, the 500 volume will ventilate only 1 lung, and you will have increased plateau pressure and peak pressure. Make sense? The other question is 25-year-old female with status asthmaticus intubated was doing okay on vent, peak pressure 25, plateau pressure 10. ICU nurse called you because the peak pressure went to 50, but plateau pressure didn't change much to 12. So we have increased peak pressure with no change in the plateau pressure. Which of the following does not cause that problem? Pneumothorax, correct, because pneumothorax will increase the plateau pressure and the peak pressure. Make sense? I distorted myself to make that clear for you. So this is the pressure time curve. PEEP, you give him the tidal volume, pressure will go up to peak, then will go down to plateau. Then when he exhales, he will go down to the same peak. The difference between the peak and plateau, this is what we call resistive pressure, which means airway resistance, including your airway and ET tube. That's why small ET tube can cause high peak pressure. COPD exacerbation, asthma exacerbation will cause mucus plug in the ET tube will cause high peak pressure. The difference between the plateau pressure and the PEEP is what we call driving pressure. Plateau pressure will increase if you have simply one word, decreased compliance. And this decreased compliance can be lung, pleural, chest wall, abdomen. Make sense? So I used my picture. So my shoulder is the plateau pressure. Top of the head is my peak pressure. Make sense? So always the peak pressure is above the plateau pressure. Make sense? So let's look, if we increase, if I stand, my peak pressure or my shoulder will go high, and for sure my peak will go high. So this is the first case. Your plateau pressure went up, that's why your peak pressure went up. The difference did not change much. So other option, my shoulder will stay the same, but my head will be pulled up. So in this condition, this is increased peak pressure with no change in plateau. This is airway problem. Again, on the left side, I'm there. I pull my shoulder up, so I stand. So my plateau pressure will go up, and peak pressure will definitely go up because it's always above the plateau pressure. What can cause that? Lung, different etiologies, pleura, air or fluid, abdomen, severe distension, ileus, compartment syndrome, chest wall rigidity, it's an important thing. Maybe too much for your boards, but for ED and for us ICU, patient on high dose of fentanyl or ramifentanil, and sudden increase in the plateau pressure, think about chest wall rigidity as a side effect from the fentanyl, and you need to stop the fentanyl as treatment for that. And if the patient is very, fentanyl is short acting, but if the patient is very urgent, you may even paralyze him until the fentanyl wears off. So chest wall rigidity can happen. Or your patient is asynchronic with the vent. He's awake, vent want to give him the breath and you want to exhale, so you may need to sedate him more to improve that. Right side, shoulder will stay the same, but the peak will go up. Mucus plug in the ET tube, not mucus plug in the smaller airways. If you have mucus plug that blocks a lobe or lung, you will get high peak and plateau. Make sense? But if it's your airway partially blocked, ET tube, you may have that. That's why if you see high peak flow, you listen to the patient, see if he's wheezing, be sure you suction very well in case there is some mucus plugging in the ET tube. Sometimes the patient is awake and he's biting the tube. That's why we, even when we do procedure, bronchoscopy, if we go through the mouth, even with ET tube, if we do it in the OR like EBUS or navigation, we have to put bite block because patient can bite the ET tube and bite the scope. And we had a patient hit the scope and did not release it, and we had to replace the scope. So he damaged the scope. So your patient on ventilator, even if he's sedated, he can bite the tube, and be sure of that. Also, if the tube is kinked in your hand. Vent weaning versus liberation. So we'll go quickly through that. You may not need that urgently for July, but you can learn that in ease. But if you're weaning means we decrease the setting. I would like to concentrate on this. So when you have a patient on high PEEP and high FiO2, I usually start weaning FiO2 first by 10% at a time. Wait for a couple of hours. I like to wean the FiO2 until I reach 60%, 50%. Then I start weaning the PEEP because I don't want to lower him to 30% because you can lower the FiO2 quicker. So I go to 50% usually. Some people go to 60%. Then start lowering the PEEP by 2 at a time. 2 at a time, wait to 6 hours, then wean another 2. If the sat is above 95%, you don't have to check ABG, just follow the saturation. And don't wean more than 5 of PEEP a day. Then wait, because PEEP mechanism, it recruits alveoli. And the effect of lowering the PEEP causing de-recruitment may not show immediately, may take some time to show. So don't lower the PEEP more than 2 at a time and wait for another 4 to 6 hours to lower another. Make sense? So this is how you start weaning. Then when we reach 40% and 5 of PEEP, here, this is our policy when we start to assess them to extubate. Some places can extubate with 50% and 7 of PEEP. So different places. You need to assess 3 things. Patient needs the vent or no? And this means the patient is requiring too much oxygen and PEEP or not. So if he's on 40% and 5 of PEEP here, we can say he does not need the ventilator. Patient needs the ET tube or not. So can you tell me about patient does not need the vent and he needs the ET tube? Yeah, airway protection. Somebody is altered and not waking up, cannot protect airway. Somebody, we talked about ACE inhibitor yesterday. Angioedema, somebody with lung cancer. We had a patient few weeks ago, patient with esophageal cancer invading the trachea. Esophageal cancer, we had actually 2 patients invading the trachea. So, and we had to treat these people. So these are people that need the ET tube. They cannot protect the airway, angioedema, cancer invading the larynx also. So these people. Then your patient is ready. By readiness means the etiology that put him on ventilator got better. He's intubated for hypercardia is better, hypoxemia is better, altered mental status is better, shock requiring multiple pressors is better. So readiness is the etiology that put him on ventilator, improved. Does he need the vent? Does he need the ET tube? Why, as soon as possible, we need to assess every day if we can extubate our patient, because you can develop ventilator-associated pneumonia. I told you about this question yesterday. The Lovitin boards the most cost-effective method to prevent that is head of bed 30 to 45 degrees. You need to assess your patient every day for head of bed elevation. When you go to the room to see him, be sure he is 30 to 45. Which one of those does not reduce VAP, may increase it? D, frequent change in the vent circuit. By readiness, the pulse has improved. Patient is not on too much pressures on one small dose. If the patient is on, say, norepinephrine small dose, sedation that you use for the ventilator will lower the blood pressure. So if he has a small dose of norepinephrine, I'm okay to extubate him, because when you stop the sedation, his blood pressure may go higher and he may not need the pressure. Even if he needs a small dose of pressure after extubation, that's okay. Dr. White is here, so it will be done in a couple of minutes. Not sure. Okay, so breathing trial, you do it 30 minutes rather than 120 minutes. Equal. Study showed 5 pressure support over 5 of peak. 30 minutes, then assess. You may need or may not need ABG. Some patient came yesterday with alcohol overdose, 25-year-old, chest X-ray is clear, he did not aspirate, he's statting 100%, he's on 5 of peak, 30% FiO2, and he's awake, he's very irritable, wants to pull the tube. You don't need even to do the trial. You can extubate him immediately, right? Check he does not have any edema, he has good cough, you can extubate him, right? Some people, you can trial them. At the end of the trial, he is getting very good tidal volume, breathing very good rate. His RSBI is 20, statting 100%. You need ABG, will be fine. So he's getting good managed ventilation, statting fine. So you can extubate without ABG. Somebody with heart disease, lung disease, then you need to get the ABG before extubation. RSBI is the respiratory rate over tidal volume in liter. We talked about that yesterday. And respiratory rate and the RSBI are very important parameters you look at it. If your patient failed the trial, you need to tell me why he failed the trial, because you need to know why he failed so you can correct it. Let me tell you an example. Patient failed the trial because he was breathing 40 and his pulse went to 120 and his blood pressure went up, but he's statting 100% and he's pulling 600 tidal volume. What's the problem with this patient? Yeah, he's awake and doesn't like the tube in his throat. You may need to trial him with small sedation on Precedex or so. Different from a patient, he went to 120 rate, 40 respiratory rate, and blood pressure went up, and he was sat to 70% and was pulling 200 tidal volume. This patient is not ready. Make sense? So if you know the etiology why he failed, then you will know what to do. Chance of reintubation after extubation is 14%. Chance of reintubation after extubation, 14%. So if you have a reasonable family, you can tell them, okay, he is ready. We did the trial. He passed the trial. ABG looks good. We'll extubate him. There are chances 14% that he may need to be back on ventilator in the next day or two. So if he gets reintubated again, they will not give you a hard time. Why he reintubated? Was he extubated early? What happened? So they know that this is normal statistics, 14%, 1 of every 6 will need to be back on ventilator. Any questions? So these are the mainly slides that we talked about. I have some weaning from the APRV, but this is too much for you. So to wean from APRV, you need to lower FiO2 first to 50%. After that, you need to lower the pressure high down to 18. Then prolong the pressure, the time high to 10 seconds. Then put him on pressure support trial. So completely different mechanism. And you trial them for 2 hours, not 30 minutes. People, I can trial for 2 hours based on expert opinion, not based on studies. People on ventilator for a long time because they have some weakness. And I had a patient, I learned from this patient. Every time I tried this patient for 30 minutes, extubated, reintubated in the PM. If I tried him for 2 hours, her for 2 hours, she did fine. She had it's weaker later on the day. Myasthenia gravis. So this patient had myasthenia gravis. So if she tried for 30 minutes, she may do okay. then she gets weaker after extubation, needs intubation. If she goes for 2 hours, okay, she could pass. Thank you very much. It's time for Dr. Waidi to start. Okay, so this, okay, go ahead.
This is PE. I'm PE. If the patient is getting intubated for PE, any ventilator setting that's specific for that, and then we did learn the restricted lung disease.
So just I usually go with 8 ml per kg ideal by the weight, whatever the rate, and also this is based on your
Yeah, exactly.
oxygenation. They are more likely to be hypoxemic. They will have okay compliance of the lung if they don't have any lung disease. So 8 ml per kg, probably they are hypoxemic if they need an intubation 100%. 8 of PEEP, tidal volume 8 ml per kg ideal by the weight, then rate 18, 20. Then get your ABG, then adjust. Great. Thank you very much. Dr. Waidi. Okay, quickly and go back to sleep. So we are recording. Everybody
okay. Very good. It's okay. I like hope. And the Kit Kats are
Oh my
okay.
Okay.
We'll give them. Let's say there's a few more. We'll give them that.
Just be sure we clean the data before we leave it, so don't do them. Most of the people are back.
Right.
Okay, I know some of you work with Dr. Waidi, who's our endocrinologist, and he will talk to us about endocrine emergencies for the next hour and a half. So, very good lecture. I attend it every year, so I hope you will learn from it as much as I learned.
Very
Thank you,
good.
Dr. Waidi.
I appreciate it. Next year, we might need heaters though. It's going to be this chilly outside.
I hope it's not raining.
No, it's not. I ran across the grass here through here. So, let's see. There we go. And we have, very good. Although I guess I need the mouse, don't I? Because we're on. Okay, hopefully I'm loud enough for everybody in the back. Is that, we're good? Okay, good. So we're going to use cases and then talk about some pathophysiology through the way. And hopefully we'll get through all the cases because that's how you remember. I think you remember most by the patients you see. All your faculty would like to think that you remember what we teach you and what we tell you. The honest fact is you'll remember very little that I said this specific thing, but you'll remember your patients forever. And so anything that I teach you or any of your other attendings teach you, if you can put that with a patient, then it'll stay up here. And that's where you need it, right? So 24-year-old guy with type 1 diabetes presents to the ED with flu-like symptoms for 3 days. Okay. Complains of polyuria, polydipsia, nausea, abdominal pain, lost 5 pounds in spite of drinking water and orange juice. His home regimen includes Lantus 30 units at bedtime, Humalog 10 units with meals, which he didn't take because he was ill. Okay? It's the common thing with our diabetics. They feel ill and we teach them Humalog, the short-acting insulins. That's for food. It's not to fix your sugar. It's for food. If you eat, you take it. And so they hold it sometimes when they get sick. He's tired, has dry mucous membranes, temp is 101, heart rate's 110, respiratory rate 26, blood pressure 110/70. UA shows glucose and acetone. His glucose is 380, not too bad. We see that every day in my clinic. Sodium 140, potassium 5.5, bicarb 5, creatinine 2.2, acetone 4+, pH 7, PCO2 10. And so we're going to talk about diagnosis, treatment, insulin doses, and the electrolytes that you see there. Okay. Oops. All right. Okay. I'll get used to the little mousy wheel. So he's got DKA, right? I mean, that's pretty obvious. And there's specific things I look for when I look for DKA. So hyperglycemia, that doesn't have to be as high as you think it is. You know, we see people who are 800. I mean, they don't all have DKA. They can have hyperosmolar syndrome, right? But you can have 300 and be in DKA. Right? And that actually happens more than it used to happen. And it's because when people are sick like this, and they know they're sick enough to come to the hospital, they grab their Humalog, give themselves a shot of Humalog, and then they come. So they're dropping their glucose on the way in. Of course, that does nothing for the DKA, one shot of the Humalog. And so you look at them and you go, well, it looks like DKA, but boy, that sugar is not as high as I'd expect. So don't get fooled by that. Sugar can be anything. Ketones, you can measure either urine or serum, don't care. It's an anion gap metabolic acidosis, and that's what you have to have. And on our patient, we had that. It requires an absolute or relative insulin deficiency. And so that means that you can have type 2 diabetes and still get DKA. Not as common, more common in type 1 by a landslide. There is a group, and I'm going to let you know this because of a change in term, which drives me nuts sometimes. but that's what happens. You'll see it through your career. You'll learn something, and 10 years from now, they're going to change the name of it. And it'll take you a while for your brain to readjust. So we've known for years, many, many years, that there's a group of usually African American type 2 diabetics who are more prone to DKA. And we used to call these, and I would still call them, ketosis prone type 2 diabetes. Okay? Or if you want to say DKA prone, but ketosis prone type 2 diabetes. That describes exactly what's going on. Apparently in New York, there's an area that's got a higher density population of people who are at risk for this. So what do? They name it after that area. And so this is now called Flatbush diabetes. That certainly doesn't make as much sense as ketosis prone type 2 diabetes, which tells you more about the pathophysiology. But I need you to know, if you hear or see Flatbush diabetes, that's what they're talking about, okay? And it's just because of that area in New York. I don't know who makes the decision to change names, especially when it becomes less clear what you're talking about. But that's what they're talking about if you hear that. Often happens with a new diagnosis of type 1. People don't know they have the diabetes, and they present, and that's how the diabetes is found. Most common, particularly here in our population, is the non-adherence. Okay? Tends to be younger people, usually in their 20s, maybe early 30s, but usually in their 20s. Where I was before, the staff asked me how I collected all this group of teenage girls that would always come in with recurrent DKA. I said, well, you know, it's their personalities and how they respond. Teenagers, you know, face it, they're not mature yet, right? Okay. And you guys are all a little older, so you can remember what I'm talking about. I can't remember anymore, but and I'm sure I was a perfect teenager. But they would come in if they had a fight with their boyfriend. They didn't take their insulin. They had a fight with their parents. They didn't take their insulin. You know, I had a young lady that she lived about 40 to 60 miles away, and so she'd go to this little local hospital. They couldn't do an insulin drip. Sometimes it was manned by a nurse practitioner, the ER, you know. And so she'd get a ride to the big city, and we'd admit her. And the ones where the DKA is from skipping the insulin, and you guys have all seen that, everybody's seen DKA. Yeah. So those are the ones that by the next morning, they're fine. They turn over really fast because they're not really sick. They just skipped enough of their insulin to get them in trouble. Okay, those are not the ones they're a hassle because they keep coming back, but they're not the ones who have serious illness that push them there, that we have to deal with a lot of other things with. Okay, so we came up with a plan for this lady to treat her, and they'd call me with her sugars, and we'd give her sub-Q Humalog. Right? It's just not enough insulin. So you would do that, and we'd hydrate her, and we'd prevent her from getting the secondary reinforcement, which was a lot of attention and an ambulance ride to the big city. And so after doing that several times and sending her home, she figured out what the answer was. And the answer is to wait longer so that she'd be sicker when she came in. She managed to come in and have her bicarb be unmeasurable. So less than 5 is what we can measure. And so that ensured that she got her ride to the big city, right? And then all the attention from her parents and her boyfriend, et cetera, et cetera. You can only do so much. They can always overcome what you're trying to do. It's up, you know, you don't have control over everything they do. Illnesses, so strokes, heart attacks, trauma, sepsis, infection, pancreas damage. I saw a very interesting guy today, just today, okay? He came in a year ago with severe pancreatitis. I can't remember if he had DKA or not at that time. I think he did. I didn't see him then. Triglycerides were over 6,000, okay? Glucoses were high. He was treated, put on insulin, sent home, disappeared, hasn't seen anybody. Comes in today, he's on 0 medications. A1C is 5.2. I think it was 11 when he got admitted. Okay. So his acute pancreatitis was from those triglycerides that were so high. Caused enough acute destruction that he developed DKA. However, they actually measured his C-peptide. I was glad to see that, and it was elevated. So he, back when he had the DKA, so it just wasn't enough to overcome everything else that was going on. And so it was from alcohol and the high triglycerides. And it looks like he did not do enough damage for it to be permanent. Now, he has not completely stopped drinking. His triglycerides were 400 today, okay? And he had stopped all his medicines. If he has another episode, I'm not going to guarantee that he's going to recover from that, and he may develop permanent diabetes. Sometimes one episode will be enough. I had a Hispanic guy, his triglycerides were over 20,000, then they quit measuring, so I don't really know how high it was. That one episode, he was not diabetic beforehand, permanent diabetes, just destroyed his pancreas. Okay, so it only takes one. And then there are drugs. The one I like to point out is the thiazides, and it's because of the difference. Back when I was an intern, the first blood pressure medicine used was hydrochlorothiazide. You guys use hydrochlorothiazide? Of course. The difference is we started at 50 milligrams. Okay? You guys aren't using 50 milligrams. You're starting at 12 and a half. Okay? It turns out if you go to higher doses of hydrochlorothiazide, you have a risk of causing diabetes. So as an intern, I dutifully put this, I'd say elderly, but she's younger than I am now. She was in her early 60s, and I put her on the 50 milligrams of hydrochlorothiazide, and by Thursday, she was in the hospital in DKA. Okay. We still occasionally will use high-dose hydrochlorothiazide. So we use that sometimes in stone patients to try and decrease the calcium production. Okay? So we still need to remember that those high doses, they're not for free. You know, they can cause other things. And this is one of the things that nobody ever thinks about anymore, because you don't see it at 12 and a half and 25. But if you push those doses up, you can still see this. And cocaine does a lot of bad things and can push you into DKA. Mortality is very low, okay, 5 to 10%. Usually that's with some underlying medical problem, not the people who just skip their insulin, right? And it's, but it's very low. You know, sometimes it's hard to figure out when you should treat and when you shouldn't treat underlying causes, and we'll go through that a little bit. Insulin deficiency, again, we talked about. Glucagon excess, not so much. And then the other hormones, they really don't cause a significant amount, but there's stress. So catecholamines, cortisol, and growth hormone all increase your glucose. So they're just adding to the problem. And of course, if you have this, you're stressed. So you have all of these extra hormones adding to what's going on. It's interesting because you've got the glucose, and yet the body's starving. And that's because it takes insulin to get inside the cell. So it's not a shortage of glucose that's the problem. It's that you can't feed the cells. And that includes the brain cells. Okay. So everybody got a candy, right? So that you don't get low on me. Very good. And the body has to use something else. And so the first thing that happens is you up gluconeogenesis. Okay. Because the brain says, hey, you're starving me. I need more to eat. So the liver says, fine. Your sugars go up, but there's no insulin to get inside. The brain says, hey, I need more. So gluconeogenesis goes up. Nothing happens. You still can't get in the cell, right? And so signal comes, says, I need more. Liver goes, you know what? I already gave you more. Forget you. I quit. And it shuts down gluconeogenesis. The brain says, you're not worth much to me if I die. The brain says, okay, I'll sort of buy that. So I need food. So it takes the free fatty acids and generates ketones. Very inefficient fuel, but it is a fuel that the brain can survive on. And so that's the mechanism to save your life is to generate ketones so that the brain can function for a while. Again, very inefficient, but life-saving at the same time. So that's basically what I've gone through. The down here, the ketones, they're in equilibrium and we can't measure them all. And so we can measure some, but the idea and the goal of treatment is to empty all the ketone boxes. That's your goal in treating DKA. It's not to fix a blood sugar. It's to empty the ketone boxes. Okay? And if we can't measure all the ketone boxes, how do we know when the ketones are going to be gone? Anybody? I heard anion gap. Right. We can use the anion gap to assess when the ketone boxes are empty. Okay. So, again, very inefficient fuel. Presentation, you guys know this. Polyuria, thirst, weight loss, blurred vision, weakness, abdominal pain, nausea, and vomiting, 70%. And this is a problem because, again, you have to try and figure out whether there's a cause other than skipping insulin. So does somebody have a hot appendix? You better take care of that or you're not going to resolve the DKA. Or is the abdominal pain just from the DKA? And sometimes that can be really hard. That can be really hard. Confusion, mental status changes, tachycardia, hypotension, hypothermia, leukocytosis. Again, a problem. Because is that because there's an infection? Or is the white count just because of the DKA? Very difficult. That's where your clinical skills come in and where your physical exam comes in. And I always think we don't teach and do enough physical exam, but that's my bias. The electrolytes, anion gap, CO2, ketones. Those are the three biggies, right? So I've seen anion gap with normal CO2s, okay? And you can have some ketones. Nobody has ketones right now, but you may have had an hour ago. And most pregnant women have ketones. In the morning, most of us probably have ketones, but they'll be trace ketones. They're not going to be, 3+ or measurable in the serum or anything like that. So if that CO2 is not low, then you've got to look for some other cause for your gap. All right, that CO2 has to be low. Blood gas, I'm fine if you guys get one. If you get more than one, you should be doing it on yourself. You really don't need to document more than one. They can be painful. Amylase, lipase, again, think about the abdominal pain. Lipids, I already told you a couple examples where it was from triglycerides, so that's important. CBC, again, the degree of leukocytosis, if you see 50,000, I'm going to tell you there's probably an infection. If you see 20,000, you're on the border where it could still be from decay. And that's a pretty good white count, right? So that's your exam. EKG, important, and that's because of the potassium. We'll talk about that. Cultures and chest x-ray, if they're indicated. Treatment, remember your ABCs. You got to have a good airway. Best example I have was, I forget, I think he was 17, 18-year-old kid in a motorcycle accident, and he fractured his jaw. So it was wired shut. He had type 1 diabetes, seemed to be doing well, was sent home. And I was a student at the time. The attending said, I want you to call me in the morning. He told mom, when he gets up, and let me know how he's doing. So we made rounds, and mom didn't call. So he called mom. Now, I don't know how many people would actually do that, but he called mom and said, hey, I haven't heard from you. It's about noon. We finished our rounds. And he said, what's going on? I thought I told you to call when he woke up. And she said, well, I haven't been able to wake him up yet. Okay. So they called an ambulance, brought him in. And it was, to me as a student, and still very impressive. We had an ENT there. His jaw's wired shut. Kid's unresponsive. Okay? He needs to be intubated. Really nice situation. One of the ENTs was there, put his scope down one nostril and intubated him down the other nostril visually, and there was no aspiration. His sugar was 1,080. His potassium was 10.8. This is a young kid. And he went home the morning before with a sugar of about 80. Very fast, very rapid progression. And what it turned out to be was from non-healing of the fracture. Was not healing. So sometimes it's amazing the things it can push you in. We're so used to just seeing the people that didn't take their insulin that we get a little cavalier. So that's why I'm bringing up these other situations. They are dehydrated. Imagine this guy's had sugars of 1,000, right? He's peeing a lot. So, lots of fluid. Most people would give normal saline. I would tell you dump the first liter in, maybe more than that, depending on the sugar, just wide open in. They're going to need it. And then you can slow it down after that. Yeah. Okay. Insulin will suppress gluconeogenesis, lipolysis, and the ketosis. It's to drive the ketones out. Here we use Humalog in our drips. That's a little unusual. Most places you go to use regular. They're going to work the same. Remember, the differences in the insulins have got to do with the absorption from the injection. If you're delivering it into the blood, the half-life's 6-7 minutes for every insulin because it's already accessible. Okay, so don't let that bother you. And you can do it weight-based or that's the best way. I think our protocol is split based on a weight, but slowly it's getting better. You don't want to drop over fast, depending on how fast they got there and how high it is. So the ones that come in and they're 500-600, that's not a big deal. 1,000 is a big deal. I had a guy who was 2,000. You want to really go slow on that because your risk is cerebral edema and herniation and death, right? So the insulin, it's important to recognize when to start it. So potassium is important, and we'll talk a little bit more of that. But if it's less than 3.2, remember, insulin is going to drop your potassium. Why? Because it's driving it back into the cell. Okay, so once you start to give insulin, your potassium is going to go down. Everybody in DKA is whole body potassium depleted. That kid whose potassium was 10.8, he's whole body potassium depleted. Okay, so when do you give the potassium? Yeah, when it gets down, before it gets to normal. And certainly before it gets low. Otherwise, you're never going to catch up. And I see that all the time in the hospital. We're behind on the potassium. Okay. One of the reasons is the protocol has a potassium replacement in it. I didn't write that. I was told that's what had to be used, and it's inadequate for DK. So do more than what it says on that. We've tried to adjust it. After a number of years, they finally let me tweak it. I kept telling them it didn't work. But even the guy with the 10.8, he needed potassium. He had a really cool EKG. Dr. Buija after me? Oh, okay. They will tell you that what you get is a sine wave as the potassium gets really high. This kid, his T waves were higher than the QRSs. So it was incredible. So you drive it down. And again, your goal, your sugar is going to come down too, right? Okay. And so as you give the insulin, again, you want to drive the ketones out. So you have to keep the insulin high. So we have two different kinds of drips for the insulin drips here. We have one that goes up and down depending on the sugar. That's actually for fixing the glucose. The other is part of the DKA protocol, and it's a fixed dose. So it could be 5 or 7 or 10 units, whatever you end up with, but it's a fixed dose. And you don't want to have to decrease that. You want that high to get rid of the ketones. but your sugar is going to come down. So how do you compensate for that? When the sugar gets in the 250 range, you add D5 so that you can maintain your sugar in order to maintain the high level of insulin that's needed to drive the ketones out. Does that make sense? Okay. So you don't want to dial back on your insulin if you can avoid it. Okay. When do you stop IV insulin? Well, not as early as you guys are doing. That's a simple answer. People don't really go back into DKA. It's they're not getting covered. Okay. One of the easiest things you can do to protect yourself is to make sure that you've started the Lantus even while they're on the IV insulin. We used to have a line when we first started protocols 25 plus years ago when I first started writing them, that said stop all insulin and then run the protocol. And a lot of hospitals, it'll still be like that. What I've learned through the years and the people I teach now, it doesn't say that. It says continue your Lantus or give the patient Lantus and start the IV insulin. That gives you some coverage so that when you want to transition off, you're not going from IV to nothing to starting something, because that's what causes the problem. Remember, I told you the IV insulin lasts about 6 minutes. That's the half-life. So in 30 minutes, it's gone. Okay. It's a protocol, and if it was followed, it says that when the order is given to turn off the drip, you have to wait 4 hours after giving Lantus or 2 hours after giving Humalog. That's not what happens. It's not what you guys do. It's not what the nurses do. The nurses see the order, they go and turn the drip off, and it takes 2-3 hours for the insulin to come up from pharmacy. In the meantime, after 30 minutes, there's no more insulin on board. What happens to the sugars? They go up, person can go back into DKA. But if you have Lantus on board already, you buffer that and you protect that patient against that problem. So we would say, get the Lantus on board. Get the Lantus on board. Try not to do things in the middle of the night. I think everybody would say that. You don't extubate somebody at 3 in the morning, right? You wait till the staff is there. You want the anion gap closed. You want the bicarb. To me, it doesn't have to be normal. I'd say above 18. And the glucose, it says less than 200, but the reality is, remember that you're given glucose, so you're keeping it between 150 and 250 so that you can keep your insulin. So it's going to be a little high. When to give bicarb? There's controversy about that. And in general, I'd tell you avoid bicarb. But the guidelines would tell you if the pH is less than 6.9, it's okay to give bicarb. Some people say 6.7, that's pushing it, but certainly I would at 6.7. But 6.9 is what you can do. The problem is, I think you have to look at the whole patient. So I had a patient one time, she came in, I believe she had an abscess that pushed her into DKA. And she was breathing 40 times a minute. I mean, she needed to be intubated. And it was like crap. And her bicarb was, less than 5. I mean, she's blowing it all out. And I gave her bicarb. Okay. Partially because of her situation and to buy time, hoping that I could slow her breathing and allow the insulin and the fluids to do their stuff to prevent her from having to get intubated. And indeed, we did that. She didn't have to get intubated. The problem was I had a couple residents with me, and the next 3 people that came in with DKA all got bicarb. And they didn't need it. Okay. So please look at the patient and only use the bicarb in selected situations. It's not for everybody in DKA. But they saw Dr. Whitey give bicarb, so they gave bicarb to the next 3 that came in. So I grabbed them and said, stop doing that. So please don't do that. Remember the sodium. There's a correction. I gave you one formula. I really don't care. Some people say every 100 above 100, every 100 above 200. It doesn't matter if you think about it. I don't care which of those equations, because the difference is 1.6 in the sodium, the calculation. So if 1.5 makes a difference in your conclusion, you better rethink that, because that's a pretty small difference in the equation. Okay. So everybody know this, or should I go through? You know, if you had somebody who's 1200 and you use 200 as the cutoff, you'd add 16 or subtract 16 from 140 if you want to look at it that way. So you'd expect that to be 124. And so if you have a sodium of 124, it's all from that high glucose of 1200. Okay, just using round numbers for you. If that sodium is 130, that doesn't fit. If that sodium's 115, that doesn't fit. Then you have to look for other things. But always correct it so you can see if it's all from the sugar or if something else is going on. Okay, so do the corrections, please. So we talked about the potassium. Replace it early, replace it a lot. Keep doing the BMPs, less than 3.3, 3.2. Replace the potassium before giving insulin so you don't drive it down and cause problems. If it's real high, don't give it at 10.8, but recognize when it gets down to 5 to give it, because everybody's whole body potassium depleted. Phos, some people don't even check the phos in DK. I don't really care. If they're not real sick, I think it's not that important. If they're real sick, you're going to get it because you're getting a whole bunch of labs. If it's less than 1, you definitely should replace it. Some people would replace if it's a little higher even. Supportive treatment and try and figure out what caused it. The complications are obviously sugars going up or down a long way, hypokalemia, the cerebral edema, more common in kids, more common in HHS, and it's more common if you bring down the sugar really fast from a really high level, and pulmonary edema. So this patient was treated with normal saline, 500 an hour for 4 hours. Potassium is 4.2. He got 10 units of regular insulin IV, followed by 7 units per hour. This is another place where there are a lack of consensus. Do you give a 10-unit bolus or not? I don't care. Okay. First of all, 10 units isn't much. Secondly, it depends on what the nurse did. Okay, because several things happen. First of all, the insulin sticks to the tubing. So when they make a drip, they're supposed to actually dump out 50 cc's to coat the tubing. If they did that and you give 10 units through that coated tubing, it'll get there. If you're giving it someplace else or a different IV, it's just going to stick to the tubing. So you might feel better. And I know WashU's protocol, which is where I trained, says give 10 units. I think Harvard's protocol says give 10 units. But you're not always, it's not always being delivered to where you think it's going. It's not going to hurt the patient. So I don't care what you do with it. Within 24 hours, he's no longer nauseated. He's hungry, good urine output, and you can look at everything and it looks great, right? Bicarb's 19. Transition, especially in the middle of the night, if this was going on, I would transition to the titratable drip to control them. Make sure I get that they're on some Lantus and transition them off in the morning, not in the middle of the night. Okay. So you have to write that order to change the drip. And remember to overlap, and we talked about that already. We talked about this. If you're going to do stuff, sometimes you put them back on their previous insulin dose, but sometimes it's a new diagnosis, and so you have to figure it out. If you do weight for type 1, it's going to be between 0.5 to 1 unit per kilo. A lot of people start at 0.3. I usually start at 0.5 units per kilo. My partners are a little more conservative. And then sort of do it 50-50, 50% of it as bolus, 50% with the meals, and then split that up. You can do it other ways, but the weight is going to be the best. For type 2 diabetes, I use a unit per kilo. Some people start as low as 0.6 units per kilo. And again, I split it 50-50, and then you adjust based on their response to those things. Okay. ICU goal is basically between that 140 and 180. The surgeons are really into this. If they have trauma or infection or stuff, they call us because they want to see the sugars better. Fix the part that's wrong. So what you don't want to do is just keep pushing up Lantus when it's a meal problem. So you have to be able to look at that. Fix the fasting first. This bothers me a little bit. Don't be overly aggressive with coronary artery disease, and that's true. Hypoglycemia is the biggest problem. Our protocols tend to have a very low incidence of hypoglycemia. The NICE sugar study had a lot of hypoglycemia, and that's where this fear came from of being more aggressive. Okay. I don't feel like my protocol causes much, so I tend to let it do its thing and be more aggressive. Advance Accord, you know, they had a lot of patients with coronary artery disease, and so there were more complications with hypoglycemia. They also tended to have patients who had their diabetes longer. Most of them had it a minimum of 10 years, as opposed to DKA and UKPDS, where they were entered into those studies at the time of diagnosis. Okay. After an MI, we would recommend it's a little bit in a transition, I would say, but most people would say post-MI, everybody should be on insulin. If you look at the Dagami studies, immediate post-MI, everybody should be on an insulin drip. Can't quite get cardiology to do that. They will use insulin. The SGLT2s are really good drugs, and we would put a lot of post-MI patients on those, usually as an outpatient. I will tell you, though, that now we're able to actually start Jardiance in the hospital. It's on formulary, so you can start it in the hospital. So that's only been the last month or so that we've been able to do that. Okay. Before then, it was you had to fill out forms and for special treatment. So this is just a variation. If it was high with no anion gap, it's HHS. The difference is you don't have to drive ketones out. So your goal is just to fix the sugar. So you can use the other insulin drip that adjusts up and down based on the sugars. You just want to make sure you go slowly if it's very, very high. And the highest I've seen is 2000, but I've heard of a little bit higher than that from other people around the country. I had a guy that walked in the hospital. He had no complaints. His wife had complaints. Her complaints were that he was going to the bathroom a lot, and he sometimes didn't make it, and it was sticky and hard to clean up. Okay, those were her complaints. He had decided he was drinking too much. He was drinking a fifth of schnapps a day, and decided to trade that in for a case of a regular 7-Up. Okay, so who knows what schnapps are? Okay, you guys watch out for those two in the back. It's a German alcohol. Often has flavors. For some reason, what, peach? I think peach. Yeah. There you go. Ask him. He knows. So peppermint schnapps. Yes. Yes. Often a holiday thing as well. So he switched that. No history of diabetes. Walked in, measured his sugar. It was 2000. Shortly after that, he required intubation. Okay. So big problem. It took about 2 days to get his sugar down to a safe level where he actually woke up. And when he did that, he pulled out his ET tube, pulled out his IV insulin, and signed out AMA. I could not believe it. He was Native American, and he refused to be in the white man's hospital. And that was his issue. And yeah, I think he did all right. But remember, if your sugar's 2000, you can imagine how dehydrated you are. So your water deficits are even higher. Dr. Gohara and the other critical care guys will give you a formula. But I'm going to tell you that regular DKA, they're 4 to 6 liters down. And if you got somebody with hyperosmolar, they're 8+ liters down. But he'll tell you exactly how much they're down. HHS has a higher mortality rate. You can imagine you're more dehydrated. Yes.
The sugars were like 800 or something. Right on that insulin, right? The sugars actually fell really fast. It was like 800 hours. And so the eating physicians were freaking out. They're like, sugar is fine, they're really edema. Is that something we should be concerned about in adults, or is that pediatrics?
No, it can occur in adults. 800 to 300 is actually not that much. No, it's more when you get over 1,000 and you're dropping really fast. We usually say you don't want to go more than 100 to 200 per hour in even in those cases, and slower in like the 2000 guy. Okay, but there's a lot of people. I mean, if you don't even give them insulin and you just hydrate them, you're going to drop several hundred points right like that. So you're going to see that right away. You just don't want that to keep going. Okay. So again, I think I said the mortality is higher because of all these shifts. And same kinds of issues. So we want to go on. 37-year-old female comes to the ED, severe dyspnea, anxiety, becomes lethargic, hypoxic, and is intubated, 20 weeks pregnant. I'll tell you one thing about boards. You'll see more pregnant ladies on your boards than you ever will in your clinics. Okay? Half the people on boards are pregnant. I don't know how that works. Diagnosed with hyperthyroidism 3 weeks ago. Tapazole recommended, but she couldn't afford it. So she's taking nothing. Blood pressure is elevated. Heart rate 120 to 150. Respiratory rate up. Temperature 100.6. She's got a goiter, no nodules, and there's a bruit. So what do we know she has? Well, she's hyperthyroid, but she's got Graves' disease. The Brewery says Graves' disease, even before you get the labs. Okay. Bilateral patchy infiltrates, TSH 0.1, free T4 greater than 6, free T3 greater than 20, and her liver functions are elevated. So that's a little bit of a flag. Okay. What's the diagnosis and what's the treatment? She had to be intubated. She was unstable. She's got a fever. Blood pressure is up, although a lot of times I'll see it low in this situation. But this is thyroid storm. Okay. This is an emergency. Mortality is 10 to 20%. It can be really, really hard to take care of. Usually something pushed you into storm. Okay. Surgery, trauma, iodine load, infection, sepsis, you know, the typical things that bring you into an ICU, right? So, and it's a sudden release of thyroid hormone and catecholamines that just overwhelm the body. And it's serious. Again, fever, delirium, altered mental status, tachycardia, arrhythmia, hyper or hypotension, and liver failure, and you'll see the eye disease in some of the patients. So overdiagnosed, I think. We get a lot of calls for thyroid storm. Most of the people don't have it. You want to measure TFTs, BMPs, LFTs, and try and find out. There are a lot, and I know you guys probably have an app, and you can calculate the risk for thyroid storm. It drives me nuts a little bit, because if you look at this, okay, and you have somebody in the ICU, they're sick, okay? So a lot of them will be febrile. Well, look here, even just over 100, and you've got 10 points already. Agitation, mild. A lot of our ICU patients, 10 more points. So we're at 20 for nothing. GI, abdominal pain, awful lot of people. You're at 30 points. Tachycardia, here's only 119, 10 more points. That's 40. And if you have any history of thyroid, or if you have any edema, if you have edema, mild pedal edema, a lot of our patients, you're at 45. Score 45 or more, high risk for storm. That's just an ICU patient. Got nothing to do with the thyroid. If you added the thyroid, those points would be much higher. That's why I don't like the scales, is because basically you could say every ICU patient is probably in impending storm, even if they have normal thyroid functions, I guess, which is totally ridiculous, right? So I look for altered mental status, tachycardia, hypotension, fever. Those are the 4 biggies, okay? With, you know, hyperthyroid labs, not with normal labs. Supportive, beta blocker. You got to give them beta blocker, and lots of it. The half-life of your medications is reduced by hyperthyroidism. How much? Who knows? Okay. Every medicine. That means in the clinic, birth control pills may not work. You need to let your women know that. And nobody thinks of that. So how do we know how to adjust them? Well, for beta blockers, we have something we can measure. It's called the heart rate. So you titrate these things to the heart rate. So I like propranolol, but you can use other things. So propranolol, I would start 10 or 20 3 times a day if they're not bad in their oral. And then if it doesn't last long enough, you go to 4 times a day. If it just stays high, you double the dose. And it doesn't matter where you get to. Okay. Now, having said that, there is only so many receptors. So I did have somebody where the residents ended up at 120 Q4 hours, and they probably weren't able to use that much beta blocker. But if they're sick like this lady, you do an IV form, right? You're not going to give her oral, and I don't care which IV beta blocker you use. Some people say that propranolol has the ability to inhibit conversion from T3 to T4 or T4 to T3. PTU and methimazole. So again, it depends on what's going on. If you can give oral, you're going to give oral. If they're pregnant, you're going to use, well, in Storm, you're going to use PTU no matter what. But if they're pregnant, the first trimester, you tend to use PTU, and then you switch to methimazole. You can give, and this says a rectal solution. It's gotten more common. When I first started doing this, there was like 1 case report. And so we made rectal enemas and gave them the PTU that way. They now can make a gel suppository that you can use, and sometimes you can get that. Thyroidectomy, if intolerance to meds, the problem with that is you've got to get them euthyroid first. Okay, so you would give some kind of saturated iodine. So SSKI is one of the forms. And so 5 drops every 6 hours or every 4 hours. You can only do that for 7 to 10 days before you have a rebound that gets you in trouble. So you've got to have surgery planned if you're going to put them on iodine. Hydrocortisone can also help, and that will also prevent the conversion to T3 and try and block some of the effects. I wish we had more time because I have some examples, but we are undoubtedly going to be short. 64-year-old female brought by family to the ED, found at home unconscious. They don't know what she's on. They brought empty bottles. Norvasc, lisinopril, levothyroxine, Colace, Nexium. Blood pressure 100/60, heart rate 55, temperature 95.5. Skin's pale, some periorbital and generalized edema, healed scar on the lower neck, distant heart sounds, and decreased voltage on EKG. Okay, so what she got? Yeah. TSH was 120. Actually, that'd be pretty low. I had a week where I think 250 was the lowest TSH that we got consulted on. We got 5 consults that week. Somebody managed to get their TSH up to about 500. CK 2200. And on echo, she had a pericardial infusion, but no tamponade. Okay. So you gave the diagnosis. Is the CPK related? The answer is yes. okay? Severe hypothyroidism, okay? And that's more than just bad. Increased mortality. Most of the, sometimes these people are outdoors and homeless too. So the temperature tends to really rock it down in a patient like that. Clues, a scar on the neck, okay? But you got to look for it. The longer you are from surgery, the thinner the scar is, okay? So I will tell you two names, and you guys can go Google pictures later. Catherine Bell is the national spokesperson for thyroid cancer. Those of you, and you guys are so young, who ever watched JAG, she was Colonel Mackenzie, okay? And so beautiful woman in her 40s, late 40s, has had 3 kids, actress, thyroid cancer. She's doing fine. Her cancer was, her surgery was a long time ago. As a model, she wears a lot of low things. You can Google and find lots of pictures where you can see her neck. I know she had surgery. I can occasionally find a picture where I see the scar, but a lot of times I can't see it. It was so long ago. Then you Google Brooke Burke. Anybody know Brooke Burke? So she used to do Wild on E. That was a long time ago. If you see her now, it's in a commercial. She does a lot of exercise stuff. So she does some exercise commercial, but she also does Skechers commercials. So you see her on Skechers. The other thing she does, if you've ever seen the Poise commercial with the 2 women on the paddle boards, she's one of those women. And she had thyroid cancer. And you can Google, you know, Brooke Burke thyroid scar and pull it up. And there is a picture of her. It's getting a little farther down because it's getting farther from her surgery. That'll show a bright red scar. It's 2 weeks after surgery. And she's on her way to the gym. Okay. As she gets farther, if you can put dates to those things, you'll see that it's fading and it's getting harder. You can still see hers though. Hers is much more recent than Catherine Bell. Okay? So I always tell my patients. So I have patients who had their surgery a long time ago. I know they have surgery and I still have a hard time when they come and I'm right there seeing their scars. Some of them heal so well. So altered mental status, hypothermia, bradycardia. So if you have a low voltage EKG with bradycardia, check a TSH, man. That low voltage is almost pathognomonic of hypothyroidism. Okay? So look real smart. And it also means look at the EKG. They're really cool because they're really tiny. Hypoglycemia. Treatment, you got to warm them up. Most people would load with 200 to 400 micrograms of levothyroxine. Some of us would do it for like 3 days. T3 is a little controversial. If they're really severe, like this one was pointed out, I would tell you, try and give the T3. Here's the problem. The hospitals don't use it very much. It's not always in stock. It takes sometimes 3 days to get it. So if you have somebody like this and you want to give T3, call the pharmacy and ask. If they have it, give it. If they have to order it, forget it. By the time it gets to you, you're past the time where it's going to make a difference. Okay? So it's just not used very much, so it's very difficult to have in stock all the time. And give steroids and figure out, you know, what else was there. 26-year-old with type 1 diabetes, brought to the ER due to hypoglycemia, found unconscious by her husband. Per his report, she was complaining of fatigue, nausea, dizziness for a couple months, more hypoglycemia on her usual doses of insulin, doesn't use any other meds, appears tired, tanned, afebrile, little soft blood pressure, heart rate 94, sodium a little on the low side, 132, BUN 18, creatinine 0.8. Glucose was 28 and then 65 after G50 in the ED. So you go, well, you know, she took too much insulin. I want you to think past that, okay? Because the keys, the past 2 months, she's been complaining. So something's been going on, okay? So what do you think it was? Well, we have a lot of circadian hormone rhythms, okay? And you memorized that slide, so I appreciate it. So adrenal insufficiency causes hypoglycemia. That's one of the things you have to keep in mind. It's not all insulinomas. Okay? I'd like to see more insulinomas, but it's more adrenal insufficiency. And acute can be a bleed. Pituitary apoplexy is an emergency. It's more common in people who already know they have a tumor. It tends to be, the ones I've seen, much more common in pregnant women. Part of the reason is if you have a tumor and you become pregnant, that's not necessarily a big deal. But even in people without tumors, women during pregnancy, the pituitary enlarges. So if you have a tumor and enlarges, it can enlarge past the ability of the vascular component to keep up and hemorrhage. And then when it hemorrhages, it blows up. And the biggest risk is adrenal insufficiency acutely and blindness. It used to be every one of those patients went to neurosurgery. Now we found we can actually monitor most of those patients. I'm still going to come in, the neurosurgeon's still going to come in. Those are emergencies if it's pituitary apoplexy. But much more than we ever did. We're watching them rather than taking them all to surgery. Shock, hypoglycemia, and remember there's primary adrenal insufficiency and secondary. And so you guys, you don't have to raise your hand. Chronic malaise, fatigue, weakness, weight loss, maybe not. Volume depletion, orthostatic hypotension, your sodium and potassium are both screwed up, hypoglycemia. Primary is the pigmentation, okay? So look at the hands and you'll see in the creases become dark. Now you have to be very careful because there are a lot of African Americans who have darker creases. And when you look at them, you don't want to just worry about every one of them having Addison's disease. But white people, lighter colored people, definitely you wanna do a workup. Depression, impaired memory. Wait, that's all of us. And sexual dysfunction, all can come. Secondary AI has a lot of the same thing, but no hyperpigmentation, and there's no salt wasting. Okay? So that means you don't need Florinap, and the potassium tends to be okay. Diagnosis, usually we don't worry about the renins, but low aldosterone, cortisol at 8 a.m. You know, this is one of the things that drives us nuts in the ER, right? Is people get steroids right away. And so if you draw even a random cortisol on somebody who's really sick, it should be elevated, right? If they're really sick, it should be elevated. At least draw that. And if you have to give steroids, try and give dexamethasone first, because then you can still do a cosyntropin stim test. You can do a cosyntropin stim test any time of the day or night here, and they'll run those cortisols right away. So you'll have an answer in an hour and a half. All you have to do is run it. You don't have to necessarily wait for the results before you do that. And again, they can be on dexamethasone. A little change that's going on is where it should be. We give 250 micrograms of ACTH, which is cosyntropin, and measure a baseline 30 minutes, 60 minutes. And then it's what's the cutoff? Classically, the cutoff's been 18. There's some evidence that you can go a little lower. So probably 16 is still okay. There are some people who say, oh, it has to double. Well, you know, if it's 3 and you double it to 6, that's a fail. That is not enough. Okay. If you draw somebody's random cortisol who came in with trauma or something, and you're worried about this, and their random cortisol is 30, there's nothing wrong with their adrenals. They responded appropriately to the stress they're under. Doesn't mean they have Cushing's either. Okay, so keep all those things in mind. Treatment, draw the labs, but they need volume resuscitation and they need steroids. Those are the two things right away. If they have primary, they need some Florinef. Is that my time limit? And try and find the cause. For primary chronic adrenal insufficiency, we recommend that people wear a bracelet or a necklace. Because if you can't tell them that you're adrenally insufficient, you know, you could die. You're in a car accident, that's trauma. You need steroids. Okay. And if you're knocked out unconscious, you need that on there. I have a guy, we say the same thing for diabetics because of hypoglycemia. And I have a guy that took a different approach because he doesn't wear jewelry. And he has a tattoo about this big that says type 1 diabetes. It's huge on his arm, and his arms are bigger than mine, but he's got this big hat too. You can't miss it, right? And it's actually really well done in multicolors and everything. So that would be another way to do that. Stress doses. This is actually becoming a little bit of a problem. So there's nothing that we can measure that tells us what dose to use. Okay, so standard doses tend to be 20 of hydrocortisone in the morning and 10 in the mid-afternoon, which most people don't take. They take it at supper or bedtime instead. But it's supposed to be mid-afternoon. It's supposed to try and get that circadian rhythm. Okay? Prednisone would be 5 and 2.5. Now, some people will collect fluid and become cushingoid on those doses. And so we tend to back off them based on their response. Okay, so somebody may end up on 10 and 5 of the hydrocortisone. And so previously we've told them, you know, if you're stressed and you're sick, double your dose. Now I can't say that anymore because if you're on 10 and 5, I really want you to go to 40 and 20. Okay? So you got to quadruple your dose, not double. So I think we're being more specific about what dose we want them to go to instead of saying double your dose, because we're tending to go down on doses to get them with less side effects. Does that make sense? everybody? Yeah, I don't know anybody that uses DHEA for adrenal insufficiency. And most people are not measuring their renin levels, although probably we should. Secondary, same kind of doses and everything. They just don't need any Florinef. One of the other things to keep in mind is that this can occur in the setting of multiple autoimmune diseases, so polyglandular autoimmune disease. Typically, you would talk about type 1 diabetes, hypothyroidism, and adrenal insufficiency. Okay. The old name for that was Schmidt syndrome. The newer name is polyglandular autoimmune syndrome, and there's a type 1 and a type 2. The issue becomes that it is critical to know whether your patient has that. You have to give the steroids before or at least concurrently with the T4. If you give the T4 first, you can induce an adrenal crisis because you're revving up the metabolism, but you don't have the cortisol to back it up. Okay? So you don't, always bad. There used to be, and just tells you how old I am. Actually, my boards weren't like this, but prior to me, the boards were, if you, our practice board, if you took your board question and you did something to hurt somebody, you lost points. You got a negative number from it. Okay? And if you took somebody to an unnecessary surgery, or they died from the treatment, you got negative numbers. So you could actually go down in your score. You guys are lucky. All you get is a 0 if you make a mistake like that. So you're going to do that. But you don't want to be doing those things. That's the important thing, is to not let somebody get hurt because of giving you medicine in the wrong order. And we think about thyroid so much easier than we think about adrenal insufficiency. You know, and believe it or not, thyroid, T4, all the generics, and Synthroid and Levoxel, all those, if you add all those together, is I think still the most prescribed medication in the US. That's amazing. I think they're wrong, but that's what the statistics show. And the reason I say they're wrong is because they separate some of the insulins. And so you've got multiple subcomponents of the insulin. And I think if they put all the insulins together, that would be pretty high too. So, okay. Coverage for illness. You need stress doses, and it depends on what's going to go on. Okay. For a long surgery, you need 100 milligrams in pre-op before surgery. For a short surgery, you might only need 50. For cleaning your teeth, I wouldn't give anything. You know, some of the dentists get, well, do they need? No. Even this says moderately stressful barium enema or endoscopy or arteriography. I don't know how, having had one of those many years ago, we don't do these much anymore. I think 100 is overkill for that. And if you have a major surgery, you've got to keep it going and give those stress doses for several days. And you can go back if it's, you know, if you give 2 days of 100, theoretically, you could go back to the 20 and 10 after that if they're very, very stable. Now, I don't see that very much. We see them drop them in half and drop them in half and then do that. And that's plenty safe. But if it's very short, you probably can go right back to where you were. Cortisol should increase 5 to 10 fold. You know, if you're critically ill, the Cosentropin stim test may not be beneficial or accurate. The other thing to recognize about the Cosentropin stim test is that it looks for chronic adrenal insufficiency. So if you have a patient who has a car accident, hits their head and shears their pituitary stalk, and you do a Cosentropin stim test on them, they will pass, but they're adrenally insufficient. So that's scary because we're not looking at stuff like that. Same thing happens if the surgeon gets in there and cuts the stalk. They'll pass the Cosentropin stim test because the adrenals have not had a chance to say, I'm not getting any signal, I have an atrophy, I'm still working fine. So if you give me the signal, I'll give you the answer. Does that make sense? So, you know, it's a rare situation, but you have to keep in mind that can happen. Okay, a few minutes for questions. No? Well, I can tell you about my worst thyroid storm because that I love telling the story and it's scary. Lady was about in her 30s, had hyperthyroidism, scheduled to see my partner the Wednesday coming up. She had the poor taste to go ahead and blow a hole in her duodenal ulcer the Friday before her visit with him. And so she had to have emergency surgery to oversew the rupture. And that was a Friday night. Everything happens on a weekend, right? Saturday morning, I'm on call. I got called. This was a little remote hospital. And they said, you know, this lady's heart rate's 140. She's hypotensive. And, you know, they gave me a story. And I said, you know, she's in storm. You need to give her more beta blocker. You need to do this and this. And they went, no, you don't understand. We can't take care of this. We're sending it to you. Okay. So that's fine. She made the trip. And one of the surgeons agreed to help me. Not much he did other than say, you can't use anything in your stomach for the next 3 days because of the recent surgery. Well, that's where we started learning about giving rectal PTU. Okay. And then again, that was the first time I had done it. One case report. The book says give sodium iodine IV. I actually wrote for that. I'm so proud of myself that I found that. I got a call from the pharmacist laughing at me. They don't make it anymore. It's still in the textbooks, but you can't get it. So she was awful. She had mental status, unresponsive, hypotensive, tachycardic. It was bad. It was bad. And so, I mean, I actually told her husband I didn't think she'd make it. And Sunday night, the hospital called me, the pharmacy, and said, are you going to go up anymore on the IV beta blocker? And I said, well, we're running just about 100 or 105. They said, if you go up anymore, we're going to run out before we can replenish Monday morning. I went, I guess I'll live where we are now. I couldn't give the SSKI because that's oral. But I remembered the old days when instead of the scrubs that we use now for surgery, everybody got scrubbed with betadine. And so we knew that if you had a big abdominal surgery or a cabbage, and we did a thyroid uptake and scan, the uptake would be 0 because you would have absorbed the betadine through your skin. Okay. So I wrote an order for this lady to have a betadine scrub every shift. Yeah, I got some weird looks from the nurses. Okay. The lady actually made it. Okay. 2 weeks later, she showed up back in the ER, our ER, she came to ours, with asthma attack. And so by then we had her on PTU, high dose beta blocker. My partner was on, I was very glad for that. And he was much smarter than I am. So what would you guys do? This is bad, right? I mean, this lady was sick to start with. Nobody does anything? She's in the ICU again. What? No, she's having an acute asthma attack.
Nebulization. Stop beta blocker.
So that's what most people would do. Like I said, my partner was smarter than I did. He did a CBC, which showed sky high eosinophils. And she was having an allergic reaction to the PTU.
Oh.
He stopped the PTU, continued the beta blockers, asthma attack went away. Okay. And then we were able finally to ablate her, make her hypothyroid, and she's fine now. Okay. But it tells you how many things can go wrong. And the more you know about the pathophysiology, the better off you're going to be in adjusting for those things. So, oh, I looked at that and just realized that that one doesn't work. Okay, very good. If anybody has a question, I'll be here for a few minutes, and you have one more talk, right? Okay, very good. Let me.
Thank you very much, Dr. Whitey. I appreciate it.
Do I need to do anything there?
Just, yeah, pull that. Okay, we'll have 2 minutes. Then come back. So we'll start the SELF. We'll be
Hi.
back here.
How are you doing?
Good, how are you?
You have the PowerPoint?
Google.
Yeah, check that out. Oh, you have yours online?
Yep.
Just download.
Yep.
Oh,
Thank you very much.
I know. There's some of those, I almost want to give them more tools. Because some of the cases give me a little bit weird options. I don't Yeah. Oh, really? Because he was here. And Mark was here. Really? Wow. As you know, you take Thank you. Thank you. Thank you. I'll just keep working. In this,